but we have the risk of spillage in Wilms tumor. So be careful, because when you increase the volume, you can have spillage. So I want to be very careful, because we have more and more volume of tumor. Need for plain surgery, and we have no force feedback. And now the Da Vinci will have the force feedback. So we replace the force feedback by the eyes, because if you do a lot, you can use your eyes as a feedback of force. It's strange, but it's doing well. So we can't have perioperative ultrasound examination. They have in adults, so it's a good way to appreciate a tumor in a kidney and the limit of the kidney. But it needs a 12 mm trocar, so it's a large one, so we don't use in children. So this is the perfect friend of a surgeon, 3D reconstruction, and we can also have fluorescence guidance. So this is reconstruction. You can have the limit of the tumor. If you have a complex case, this is a tumor of the spleen, and we wanted to have the limit and to have the artery to select cases and to make a conservative treatment. And this is an 11-year-old with renal cystic lesion. You can see the lesion at the lower part of the kidney. And if we have reconstruction, you can see the little artery. Marche plus ça? Si ça marche. The little artery here we can use for partial nephrectomy. So we decide to do it by robotic, and we decide to use green endocyanin to have the limit of the cyst. Clearly, the limit of the cyst you will see after, because it's black, and you have the limit of the kidney. So this is the cyst, and we can resect after control the artery. And we have nephrectomy, atypical nephrectomy, as you see, and we follow the plan of vascular plan. So it's because we don't want to spillage the cyst in case of course, cystic nephroblastoma, but the child is 11 years old, but we can have also else tumor. So we need to have a good resection. So in this case, we had good margins, and we control the kidney by stitches we put to suture the kidney, the parenchyma. This is. And we put blue with the ureteral catheter to see the lack of the urine. This is a 14-month-old girl with left renal mass, umbrella protocol. And after chemo, we had lymph nodes. So we need to have lymph node sampling in nephroblastoma. So we need to search for the lymph node. And we pick the lymph nodes. And you need to have 6 lymph nodes to evaluate a WIMS. So in the recommendation, so the surgeon has to pick up, and sometimes you are tired because you have a laparoscopic procedure, you want to finish, but you have to resect the lymph nodes. So this is, you see a big lymph node you have to take. Alors, moi, je peux enlever. Comment ça passe? La suivante. Okay, this is the... You can see you control the artery. And control the artery, you put the green endocyanin, and you see the lymph node behind the artery. So for the WIMS, we like andocyanine because we put it 30 minutes before clamping the artery, and it's a good way. We tried a lot of with 24 hours, 1 hour, and 30 minutes before clamp. It's nice. We can see well the lymph node. You see? So this is different teams. We propose now in Robert Debré injection 30 minutes with the anesthetist before to clamp the artery. And I show you a 4-year-old boy with adrenal neuroblastoma with lymph nodes and bone and medullary metastasis, non-amplification of NMIC. So you can see the tumor, segmental profile. And after chemo, we had still image-defined risk factor, as you see. And we wanted to do surgery before high-dose chemotherapy. So we decided to do reconstruction to know if we are able to do it by open surgery, or we can propose robotics with safe control. So this is the reconstruction, and you can see well that the artery and for the spleen is nice, and you can have the vein with the adrenal vein is coming in the tumor, and the renal vein we can dissect. So we choose to take the robotics procedure, and I show you the dissection. So you have the kidney here, and you have the tumor here, and we control the artery go to the tumor, the vein also after, and we have exactly the reconstruction, the same as we discover in the robotic approach. So we know we had no surprise, and it's a good way to do it, I think, for complex case. If you don't want to make conversion or try for trying, yeah, let's go, we can do it. So I don't think it's a good way to do. So, and here, because you can't have palpation, you have to have a good radiologist to search for lymph nodes. She told me that there were lymph nodes, but I couldn't see it. But when you search, you find. So you can have palpation, but you have to find it. You know that you have. It's a pity when after the oncologist say to you, oh, you have a big lymph node after surgery. I have the CT scan, okay? So I don't want to have this, so I have to search. So if you search, you find, okay? And this is an 11-year-old girl with gross hematuria and the cystic mass of the kidney. And because of the cystic mass of the kidney, we didn't want to make biopsy. So we decide to do surgery first. So it's a case, a difficult case, because if you have rupture or spillage because you do surgery first, you cry as a surgeon. So we want to be able to do how will be the procedure. So we use 3D reconstruction in this case, and it was nice to do it because some people say you can do partial nephrectomy. But when I saw the cystic lesion here, but here, what is it in green? We didn't know what is it. It could be a clot because it was bleeding, urinate bleeding, but it could be also tumor. So I changed and decided to do nephrectomy, total nephrectomy. So you can change if you analyze correctly your imaging. And it was, we did total nephrectomy by robotics, pre-imaging, and it was anaplastic sarcoma. So this is a reconstruction also for pelvic lesion. We have a visio nerve with Necker and cooperate with Sabine Sarnaki for this patient. Tu fais du Carla Bruni. This is the proximity with S1 root and ganglioneuroblastoma. You see the proximity with the vessels, iliac vessels, and also the roots. Ah, c'est marrant, il y a la flèche maintenant. And this, we decide to do it by robotic procedure. And you will see clearly exactly the reconstruction when the dissection. This is the artery, pardon, very close. So it was a surprise. I didn't put a catheter in the artery, so quite tricky, but we succeed. And after, you will see the artery. So this is the artery going to the tumor and coming from the iliac vessels. So this is the reconstruction, and this is what we found at the robotic approach. So it was exactly what we saw in reconstruction. So it could be a nice preparation to your complex robotic procedure. So, and because we had the root, we decide to leave a residue near the root to have no neurologic sequelae. So we leave the residue behind the root, and we remove the tumor. It was a ganglioneuroblastoma. Okay. So we see clearly, we see very well. So it's a nice for pelvic, also for pelvic lesion. So robotic oncological surgery is safe for selected case after a certified pediatric board meeting, and tumor limits are more precise, remove compared to laparoscopy. And we can do also for syndromic children a partial adrenal resection with take only one arm of the adrenal gland. So it could be, we did it. And we have it's not a fan and steel. I open large on the trocar robot on the here to help to remove the bag with the lesion. Attends, c'était pas ça que je voulais. Bon, c'est pas grave. Hop. Ça veut plus. Bon, thank you all. Ça a marché? Non. Voilà. Thank you. Yeah. I saw it, I think 4 years ago. Someone show me the robot, and I say, can you use it? But I think for the equipment, it was difficult. That's it. Yeah. Yeah. It's very expensive, and it's very expensive to control the robot every year to check. This is the maintenance. Yes, and for tumor, it's helping a lot. You know, now adults, they do, for many cases in cancerology, they do robotic procedure. No more open procedure. So if you want to do the first case of neuroblastoma for children in robotic procedure, I can help you. Yeah. If we find we ask Da Vinci to, if they maybe we can tell. Mm. Yeah. Mm. Mm.
Instruments are smaller
Yes.
than the 5 mm. The 5 mm, the tip longer, so it's much difficult to move inside the abdominal cavity of the baby. But I saw the technique are excellent.
The youngest child we did is 3 months, 5 months old. It was a neuroblastoma. I didn't show you, but sometimes we are afraid because we have the robot, we have the baby in under, and we don't see the baby because the robot is on. So I can't see the baby when I am on the desk for the robot. It's strange. Yes, the baby is there. Okay.
Anh em mà có câu hỏi cho giáo sư Pascal thảo luận luôn là hay hơn anh. Ok, thì tùy mọi người thôi, tùy chủ tọa đoàn. Theo em thì cứ sau bài nào là thảo luận luôn thì nó nóng.
We still do a lot of open surgery. We have to select the cases.
I know.
Of course.
Yeah.
We have a place for open surgery. Of course, we do a lot.
Because the robots are too expensive and the instruments are still too big. So we need to select the baby.
We don't have this problem, but we select because we don't need robotic procedure for all the cases. We can do some in laparoscopy and it's okay for that.
Em xin phép là sau 2 bài này thì chúng ta sẽ thảo luận một số câu hỏi ạ. Nếu các anh chị có câu hỏi đặt là cho các chuyên gia thì mời các anh chị đặt ạ.
So actually, in this hospital, we did a first robotic adrenalectomy before. I need robotic, yeah. But there we have no clip. The robotic like you. This is a modern system. Our system then we have no clip, no ligature, nothing. It's very significant.
I use a lot the hook and the spatula.
Yeah, it's a hook. Yeah,
and we can do a
yeah. But it's feasible.
Yeah.
But for normal, for usual cases, I think need the laparoscopic I can do well, you know. But you have complex cases, especially in IDIF positive, this is very difficult. Yeah. But I wonder for big tumor like a Wilms tumor, you do that, and after that you have to make incision to take the tumor out. I think this is something is not balanced. It's also traumatic for a patient. I can.
No, we don't do for huge tumor crossing the midline. We respect the umbrella protocol. Now in umbrella protocol we have a item of laparoscopy procedure. So it's the same for the robotic procedure. So if it's crossing the midline, we say no, we don't use the robot. If it's very attached to the liver, we say no. So we have recommendation and we follow the same recommendation as laparoscopy. But
for neuroblastoma, when I do adrenalectomy, laparoscopic adrenalectomy, I take out by morcellation. Yeah, so no more incision, no need for enlarged incision. But for Wilms tumor, I know you have to keep, the whole tumor to take out. So this is maybe the difference.
Sometimes we have big tumor in thorax for neuroblastoma, and we put in a bag and we cut in the bag to extract the lesion. But we try not to do. Of course, neuroblastoma is the first case. We are happy with that. We can spill it. We can resect with morcellation, but I don't like too much. So I ask the pathologist if I can do it, because sometimes the pathologist, for many reasons, he has no so much more on the biopsy. He wants more, so he try, because you don't know when you cut if you have necrosis or if you cut in the real neuroblastoma. So it's important for the pathologist to have these items after. So sometimes when you operate, and we have some cases we operate a child for primary surgery, we try to respect and to have the tumor all with the margin.
Okay. So I have a question for Dr. Jan Mission. So it's in SIO protocol, all the Wilms tumor have to be adjuvant therapy chemo first. Sure. Yes. But I think early study in this hospital, Dr. Hậu, yeah,
I know,
has shown that the percentage of non-Wilms tumor in this in Vietnamese population, general population, is somewhat higher than other countries.
yeah.
So I think at least in your statistics, at least more than 20 or nearly 30% of patient non-Wilms tumor will suffer some unnecessary chemotherapy. So I think
I agree. I agree, because I remember Dr. Hall work about that, the story of the subtype of renal tumor. I never saw the paper published. I think it's important to have the paper published, because otherwise we don't know. The thing is, as you said, we have sometimes patients who receive 4 weeks, only 4 weeks of chemotherapy for something else, which is not the Wilms tumor. But I think this is obviously we check if the tumor was regressing after 2 weeks. And when the tumor is not regressing, sometimes we discuss to have an earlier surgery. It happened very rarely. And on the other hand, as I told you, when we have atypical situation, we are really happy to ask our colleague radiologists to make a primary biopsy, because we know that the biopsy is not going to harm as long as it's done in the right way, and it's not going to transform the patient in stage 3. But I really don't understand really the story of the primary surgery for countries where a lot of patients arrive in the hospital with a very large tumor, because we know that from the 70s, in the 70s, we were doing radiation. The first PSYOP study was looking at radiation therapy prior to surgery, and then replaced radiation by actinomycin D and vincristine. And we were very happy to have lower number of stage 3 cases. And this is really established that if you have a small amount of patients who have progressive disease, but you know that if they have progressive disease, you can change your mind. diminish the number of patients who are going to receive vincristine, actinomycin D, and who do not deserve it. So I think it's important to look also at what they do in Singapore, what they do in other areas. And I think also that since these tumors are very rapidly growing tumors, we know that we need to be efficient. And when we see patients arriving with sometimes hypertension, sometimes pain, within a week, they don't need any more anti-pain treatment because they receive chemotherapy. And it's like the result of histology. I'm not saying that this is histology, but Wilms tumor is really rapidly decreasing its size under chemotherapy. So it's not a treatment, a diagnostic treatment.
Recording in progress.
It's really a reality.
Vâng ạ. Em xin tóm tắt lại một chút về tức là anh Sơn có hỏi lại trước đây thì là có một cái đề tài tiến sĩ của anh Hậu ạ, thống kê về cái tỷ lệ mà không phải là u im tại bệnh viện Nhi Trung ương ạ, thì khoảng tầm 30% là không phải u im. Thì anh Sơn có hỏi là với cái điều trị mà hóa chất trước mổ ấy thì sẽ có rất nhiều bệnh nhân phải dùng hóa chất mà có thể không phải là của u im, thì nó có cần thiết hay không ạ? Thì ông ấy có trả lời thứ nhất là ông sẽ dựa vào rất nhiều yếu tố để em xác định là người ta có định hướng đến là u im hay không. Thì hiện tại bây giờ người ta không có cái chống chỉ định với việc sinh thiết u, và cái việc sinh thiết kim đấy nó cũng không làm tăng cái giai đoạn cho bệnh nhân ạ. Thứ hai nữa là ông đã thấy rằng là có những cái thống kê là những cái bệnh nhân mà được mổ phẫu thuật ngay từ đầu mà không dùng hóa chất ý, thì cái giai đoạn của bệnh nhân nó tăng lên rất là nhiều, giai đoạn 3, và bệnh nhân phải dùng doxorubicin cũng như là xạ trị. Thế thì người ta xây dựng cái phác đồ này, người ta mới mục đích là làm giảm cái việc phải làm tăng giai đoạn của bệnh nhân. Bệnh nhân sẽ hạn chế cái việc dùng doso, tức là hạn chế cái độc tính của hóa chất cũng như là xạ trị. Và ông cũng có thấy là tức là cái việc mà dùng hóa chất này nó không phải chỉ là một cái điều trị đơn thuần, mà nó còn là như một cái điều trị để chẩn đoán. Vì là ông thấy rằng u im thì thông thường nó tiến triển rất là nhanh, và bệnh nhân đến với triệu chứng rất là đau rồi bụng trướng lên, thì khi mà dùng hóa chất nó đáp ứng một cái thì nó giống như một cái là mình đã định hướng đến là một cái u im rồi ạ. Em xin tóm tắt xong.
So the second question is about you said about the biopsy for Wilms tumor. On the literature I read, they said even need the biopsy for Wilms tumor. Wilms
No.
tumor is something like increase the stage of tumor. Yeah.
No.
So now you present in your presentation, you said that you do retroperitoneally do not increase. So anyway, you puncture, you make a rupture of the renal capsule anyway, either transperitoneal or retroperitoneal. But the spillage may be intraperitoneal, is more dangerous. But the fact is the renal capsule is not intact after the biopsy. So what do you say about that?
Can reply. So I think that when we ask our colleague radiologists about the need for a biopsy, we have criteria that I told you. On the other hand, we have also a technique which is well established now. Using this posterior weight technique, we have never had, let's say, a stage 1 who happened to relapse very rapidly after surgery and chemotherapy. So I think, and moreover, I think the most important thing is that these biopsy reply to your question, the first question about the disease itself, the name of the disease, because if we do the biopsy only in selected cases, the number or the percentage of cases who are going to be a different than Wilms diagnosis among those who are not getting the biopsy is getting much lower, because we know in which situation we have to perform this biopsy. I think this has been This has been published by Hervé. Hervé wrote a paper with de la Morandrie or something like that guy in pediatric blood and cancer. So we have a paper. I can probably find the paper for you. It was referred in my slide.
It was the definition of stage 3 is the rupture of the capsule, renal capsule. So that's why you make a.
No, we can discuss about this, but for a biopsy we do, and Leila is here to control what I say. For atypical aspect in imaging, and they are able to say with crossing with the age of over 10 years, for example, to be able to say we do the biopsy or we don't do the biopsy. And if it's typical, we don't do biopsy. We have only for cystic lesion or neonates, we do primary nephrectomy first without chemotherapy. Under 6 months, we don't do.
I think for your question is more, if I understand, if when we do biopsy, okay, we don't do biopsy most of the case. When we do the biopsy, when we use it's not a posterior anterior, when you use the coaxial approach, so we use this action with like a tunnel to put the biopsy in it and everything, it is proven not only in wounds, but in other diseases like sarcoma and everything, we don't have spillage. So it's not, I know that in theory you think that we. Yeah, so it's. Yeah, but it's not a rupture. Yeah, but it's not a rupture.
Sorry.
Yeah, and when we think rupture, we think spillage.
I just
not rupture.
Even need the biopsy or more, where the retroperitoneal, where the transperitoneal is increasing the stage.
No, depends on the.
Because maybe
No, you're right. You're right for this question, and we had a lot of discussion. Like, do we consider it rupture or not? Because we puncture. So yeah, we go through the capsule, but with most recent studies and everything, we see that it's not a rupture. Like, it's not. We change the definition. If you go for biopsy, if we go for open surgery with a big biopsy, okay, it's of course like it's a big one, but with micro-invasive needle biopsy, we do not consider it a rupture of the capsule anymore.
To take into account that now people are talking to each other. People from the NWTS and people from PSYOP, and they made meetings together in order to have the same way to call a stage 3. So they have within the definition of stage 3, you do not have the needle biopsy. The needle biopsy doesn't change it to stage 3. Okay. So that's really the reason. And I think that the problem is that these documents, these papers are published, but they are not published in journals which are accessible to everyone. So I think we have a problem of information, a diffusion of the information to everyone, so that if we do that diffusion, we are going to have better collaboration.
So we begin with some maybe papers, but when the paper and had a consensus between maybe the American group and the Israel group, and include in the guidelines when everyone to know.
Yeah, but
just some papers is not enough, because have to more trial and some.
You're right. Recently we had a case like that had a biopsy for Wilms tumor. And we discussed, do we upstage it? Because we didn't know how the biopsy was performed. So it was good, not good. So if we do it well, with well indication and well everything, we do not consider it as a rupture. We do not upstage the patient. And it's very new because we had the experience of the biopsy. But it's a good question when we don't know the condition of the biopsy. You have to know that it was done well.
In my experience, I have at least 2 cases. The radiologist said this typical Wilms tumor.
Yeah.
And sent to chemotherapy.
Yeah.
And no response. After that, rhabdoid tumor.
Oh,
Yeah,
yes, yes,
yeah,
sure.
yeah, we have that.
This is
Yeah, we have that.
even so we got typical, but this is still very.
Yes, you have, if you had large lymph nodes, hypercalcemia, or things like that, you know, you had to consider this.
And this is why we say we treat as presumed nephroblastoma, because no, it looks like, but we don't know.
Good.
Problem is the lymph node for WIMS. Because if you don't have enough lymph nodes, the pathologist can't answer you about the lymph nodes.
We take lymph nodes every time.
Yeah. But in laparoscopy or in robotics, sometimes the surgeon doesn't take so much. So it's a problem. So we have to be careful of that.
As I said, for some small tumor, I would like to me something I can do it, cut it into pieces to take out, to remove. I do laparoscopic only. But for, like say, Wilms tumor, I have to keep, or something that I prefer open surgery, still open surgery. Also, it's feasible.
When
I think to do 3 or 4 incision, 8 mm. After that, you make also 6 mm or some more centimeter incision.
no, but
Also, financially, still traumatic for a
not
patient.
financially. No financially.
So
For me,
take out the circle.
I cut the it's not financial, but
You keep minimally invasive. After that, even last.
No.
So I think that is my opinion, of course. So at that time.
No, I had the same opinion for laparoscopy. I didn't do WIMS in laparoscopy until we have the robot and we can use it. I do some with robot. It's different.
Visualization. Yeah.
Yes, very better.
Okay. We don't talk about the feasibility. We talk about the benefit for the patient.
Yes, the benefit.
Okay. Vâng, tôi dịch nhanh. Vâng, một số bạn có thể không nghe được hết. Tôi hỏi một cái vấn đề mà tranh luận. Thì tất nhiên là cái vấn đề là một số cái này mà nghe là mới. Trong các cái guideline cũ ấy, trong các cái các bạn đọc cũ ấy, thì riêng u thận, u Wilms, nghi u Wilms ấy, thì tất cả sinh thiết làm vỡ vỏ u, và định nghĩa giai đoạn 3 là khi mà vỡ u ra ngoài vỏ thì làm tăng giai đoạn và sẽ phải điều trị hóa chất theo cái giai đoạn 3, tăng rất là nhiều. Tuy nhiên thì cái bài nói họ cập nhật đây thì họ ở chỗ họ ấy, thì họ sinh thiết kim nhưng mà không liên quan phúc mạc, mà đi sau phúc mạc mà sinh thiết khéo thì họ không tính cái tăng giai đoạn. Đấy, như vậy là trái những cái guideline trước này tôi tranh luận với họ thôi. Chứ còn nếu mà họ có theo dõi của họ nghĩ đang tốt, nhưng mà cái này vẫn đang là mới, đang tranh luận chứ chưa vào guideline hết. Chứ còn định nghĩa đúng ra cứng là cơ vỡ vỏ u là tăng giai đoạn. Đấy là cái này tôi đang tranh luận với họ. Thế thì họ đối với cái trường phái các Pháp thì họ bắt đầu làm thì họ nghĩ là tốt, và họ chỉ định chọn lọc thôi mà tất cả. Đấy, như neuro chẳng hạn, chúng ta bao giờ sinh thiết kim thì không lo tăng giai đoạn, nhưng mà riêng u thận thì có cái đấy. Nhưng mà họ bảo với cái đường của họ thì họ chọn lọc một số trường hợp. Tuy nhiên kể cả chọn lọc thì chúng ta biết rồi, một số trường hợp thì chắc là ai ở đây viện nhi đây cũng bị nhiều, và chúng tôi cũng bị rồi. Tức là mình nghĩ chẩn đoán hình ảnh, chẩn đoán luôn u Wilms thì dấu hiệu điển hình thế này kia, thì điều trị hóa chất không đáp ứng, quay lại khi mổ cắt u ra thì là rhabdoid, u cực kỳ hoàn toàn hóa chất không đáp ứng, dối cái khoách của thận, và mà khi mà nói điều trị đấy u to lên nhanh lắm mà có thể là ảnh hưởng bệnh nhân. Thì sai ốp là vậy, họ chấp nhận, nhưng mà về mặt dài hạn họ thống kê ra thì tỷ lệ đấy họ vẫn chấp nhận được thế nào đấy. Còn trường phái Bắc Mỹ mà mình biết rồi, nếu u mà cắt được thì cắt luôn, có sinh thiết có thế là bên sau. Nhưng mà họ thì những cái mặt hóa anh dịch thì họ bảo với theo dõi dài của sai ốp thì là họ làm cái điều trị hóa chất trước thì đa số u thì sẽ đáp ứng là sẽ giảm giai đoạn, không phải giai đoạn 3 nữa, và khi mổ chuyển giai đoạn 2 thôi, nó đỡ bị vỡ u hơn. Thì cái đấy còn Bắc Mỹ với còn sai ốp vẫn tranh cãi suốt ấy, và vấn đề này.
Xin phép bổ sung một tí, vừa rồi thì chúng ta có đề cập tới cái vấn đề tăng giai đoạn hay không và sinh thiết như thế nào. Thì COP 2016, protocol này 2016, thì bây giờ là đi 9 năm rồi. Thì trong này, cái này là phiên bản cho đặc biệt cho giải phẫu bệnh. COP protocol thì nó cho tất cả mọi thứ, bao gồm cả lâm sàng vân vân. Thế thì cho giải phẫu bệnh thì trong này đề cập đến, thực ra ta gọi là mới vì chúng ta tiếp nhận thông tin thôi. Còn cái này nó 9 năm. Thì chu cắt và needle biopsy không upstage, ta không làm tăng giai đoạn. Nhưng mà wet hay là bất kỳ một sinh thiết mở khác thì trong này thì nó sẽ có tăng giai đoạn. Như vậy thì nếu mà áp dụng protocol này ta cứ tạm áp dụng, thì anh Sơn nói rất đúng là đây mục tiêu cho bệnh nhân. Thì ở đây nếu như ta áp dụng siêu thì cái phiên bản này nó nói là như vậy, và chắc chắn là nó có cái minh chứng ở các cái trường hợp có sinh thiết và không. Thế còn ở đây thì cũng tại Viện Nhi Trung ương thì cũng có lựa chọn những cái tình huống, một số các tình huống đặc biệt sẽ có cân nhắc có sinh thiết kim, bởi vì những trường hợp đấy thì liên quan đến thời gian, ví dụ bệnh nhân trước 6 tháng thì không làm rồi đương nhiên. Thế còn trường hợp đặc biệt thì sẽ làm, nó cũng hỗ trợ chẩn đoán mà cũng không quá lo về vấn đề tăng giai đoạn. Đấy, xin hết.
Nếu mà cái này thì thực ra
thì em theo cái tim này theo lâu rồi thì các bệnh nhân của em thì không quá nhiều. Tuy nhiên là bệnh nhân của em ấy thì nó cũng được theo đúng sai ốp, tức là nó làm sinh thiết tim hầu như và sinh thiết sau phẫu mạc theo đúng cái tim này ấy, thì bọn em cũng đã có những cái bệnh nhân mà có làm sinh thiết sau phẫu mạc và cũng có trả lời kết quả, và cũng có những trường hợp bệnh nhân giai đoạn 2 và cũng chỉ cần nhìn trên chẩn đoán hình ảnh ở bên viện ca thì họ đề nghị làm cái này nghĩ là u im và không cần phải sinh thiết nữa mà sẽ điều trị hóa chất trước rồi sau đó phẫu thuật. Thì em thấy là nó cũng đúng là nó cũng có ta làm cho cái tiên lượng sau phẫu thuật nó cũng tốt. Tuy rằng em không có nhiều bệnh nhân đến độ, tức là trước kia thì có khá là nhiều bệnh nhân nhưng bây giờ thì nó không nhiều nữa, bệnh nhân sang Viện Nhi hết rồi nên là nó không còn nhiều nữa để bọn em có thể trải nghiệm. Tuy nhiên rằng cái giai đoạn đầu của cái sinh thiết kim này thì hầu như là Việt Đức làm rất là nhiều, tức là các bệnh viện ca họ cũng gửi bệnh nhân sang Việt Đức để làm, bởi vì Việt Đức nó khá là mạnh về sinh thiết kim, nó gần như đi đầu về sinh thiết kim cho nên là nó làm khá mạnh. Ngay cả ở hình như Viện Nhi giai đoạn đầu cũng chưa làm được sinh thiết kim nhiều thì hầu như là Việt Đức họ làm cũng khá là mạnh. Thì các bệnh nhân thời đấy thì các bệnh nhân của em rất nhiều, bởi vì là hầu như là gửi sang để sinh thiết kim và làm theo cái phác đồ sai ốp của họ, thì em thấy là cũng khá là ok, cũng không tăng giai đoạn, và sau đó thì cũng phẫu thuật, ta điều trị hóa chất trước rồi sau đó cũng phẫu thuật theo đúng phác đồ. Thì em nghĩ là nó cũng khá là lâu rồi, vì bà Pascal bà sang bên em bà mổ lâu lắm rồi, thì cái đấy thì cũng làm cũng nhiều ạ, cũng không phải là cái gì mới lắm, họ vẫn năm nào họ sang trình bày đúng cái như thế này, họ cũng không phải là cái gì mới lắm. Bọn em cũng như thế.
Với chị Lan này,
Bọn em còn làm cả những cái mà lấy huyết khối các thứ cùng với tim mạch các thứ nữa cơ, thì nó cũng khá là
chị Hoa, em có ý kiến cái về ngoài cái u quim ấy, vì là cũng mọi người cũng lo là lôi cái u ra như nào ấy. Lúc nãy bà ấy mổ cả cái u nô rất là bự. Thế có cả anh Thạch, cả chị Lan đây thì anh em mổ nội soi, nếu mà ấy thì bây giờ mình kiếm cái túi thật tốt rồi, xong là mình cắt nhỏ ra rồi lôi lên ra, mình cũng không sợ nó tăng giai đoạn của khối u. Và thì các bạn cũng làm thế mà, thì khối u neuro thôi, u thận này thì để thận này để các bác thận mà. Mà.
Nhưng mà cũng tái phát ở tại chỗ trước đây cũng khá là nhiều, em cũng mổ lại nhiều trường hợp tái phát.
Guideline vào Bắc Mỹ, vào cái những cái guideline mà tôi hay thường xuyên đọc ở Bắc Mỹ ở các thứ thì họ vẫn quan niệm sinh thiết vẫn là tăng giai đoạn. Đâm mà họ vừa nói bây giờ thì siêu ốp với cả Bắc Mỹ với trưởng phái mới đang ngồi lại với nhau. Nhưng mà bạn nào mà u thận rồi mà cái u to một tí đấy, giáp danh giai đoạn 2, 3 ấy, dễ vỡ lắm. Đấy, bạn đâm ra bảo chọc kim mà không tăng giai đoạn không đúng đâu, đọc phát là mình nó toạc ra ngay. Đâm ra là anh Thạch nói thế, anh Thạch chưa bao giờ các anh mời anh Thạch vào xem mới biết. Đâm ra họ đi đường sau phẫu mạc, kể cả sau phẫu mạc thì nó vẫn vỡ ít này nhiều. Thế còn nhưng mà vì hóa chất tốt bây giờ họ điều trị nó không tăng giai đoạn không biết, chứ còn đúng là cái u thận mà nó đủ to, nó sát lên cái kia rồi chọc vào là vỡ. Anh Thạch em bảo không tăng giai đoạn không đúng đâu. Chúng tôi là mổ tôi biết, mổ chỉ cần động nhẹ phát nó thì nó vỡ rồi. Nó mà chính vì là nếu đấy thì cái bình luận của là nếu mà mình đúng size mình dự trước thì đa số nó sẽ nhỏ đi và cái tỷ lệ vỡ u trong mổ ít hơn đấy. Nhưng mà vấn đề là lại 30% là sẽ điều trị không phải cái u im đấy. Cái vấn đề chúng ta chọn như nào. Thì bây giờ nếu mà giả dụ thực sự là nếu mà tất cả các sinh thiết và không tăng giai đoạn thì ta sinh thiết thường đi chứ cái gì phải chọn lọc. Nếu mà đấy. So the question is that if you prove retroperitoneal needle biopsy do not increase the stage of tumor of Ewing's tumor, so why cannot we perform it routinely for every renal mass?
Because there is no use of it.
Oh, why? 30%.
90% of the case.
No, 30%.
17% of the case, you're going to be right. So if you wait and see if it's that or not, to see if there is atypical, if it's not responding or everything, you're not worsening the prognostic of the child if you do it after first evaluation.
How about the course of 2 weeks, the
And then you have-
chemotherapy and the course of needle biopsy? What
You
do you think?
have 70% of patients.
No,
you will
I'm
not need
talking
it.
about 30%. Because Mhm.
Actually, we are not taking into account the cost of that, because if you take into account the cost of the 4 weeks of chemotherapy, most of the patients receive this as outpatient in our hands. And moreover, you will have to take into account the cost for all
So
the
I think
patients.
this is an interesting point of view.
Yeah.
For liver tumor, we do biopsy routinely. No one
Yeah, you're right.
against that.
Yes.
So
you're-
if
Yeah, I understand.
before
Yeah.
we hesitate to do a renal biopsy only because if the dangerous, the risk
Yeah.
of increasing the stage.
Yeah.
If now we prove that it's not increased stage,
I-
why do we not perfectly?
I
don't know
agree.
the reason.
This is something we probably have to discuss with the
Yeah.
people, because I agree with you that
Other tumor, like neuroblastoma, liver tumor, we do routinely biopsy.
yes,
All
when I was around more than 10 years ago with the Swedish people, I remember the story of the hepatoblastoma, because the big surgeon, the tall surgeon was always complaining that you were not doing biopsy for. He said you have to do biopsy for all hepatoblastoma tumor, and I think that in that case we have learned a lot from the biopsy that were done for hepatoblastoma patients, because now we can have subtypes of these tumors, which can help to decide for the treatment after that. And so far retrospectively, but we have no prospectively, because when you will listen to Sarah, who is presenting the situation of the hepatoblastoma treatment, we are taking into account the histological type of diagnosis and the level, not the pretext, the histological type and the level of AFP. So we have 3 criteria, maybe the age also. No, not the age. So the 3 criteria. So we could have, for example, following your proposal, we could have, for example, a biopsy in all patients, and we would decide the primary treatment or surgery or something like that based on that. But
WIMS.
I'm in WIMS. I'm saying in the future, future. And there's another thing which is very interesting also. It was published. We have the ability to have DNA from the tumor in the blood. And we have proven in Curie that it's feasible to have DNA from the tumor. And we can even describe if there is a p53 mutation in the DNA from the tumor just drawing blood. So you can know that there is an anaplastic tumor within a couple of days. So I think it's, sometime progress in science can make progress in treatment of patients, and we can skip one step, because you will have the tumor. Our colleague pathologists will have the tumor definitely after surgery. So I think this is something which will be debated within the RTSG. So I think you have to join the RTSG group. Yes.
Now we're doing a study with some people from St. Louis. We get our over 200 cases of kidney tumors. So now half of the time running, and we do in not yet global publics, but we recognize that at least 3 things difference. The first is the ratio of the kidney tumor is actually less than in Europe, and the other is around 70% of the WIM tumor. Second thing is about anaplasia. That really difference. We around 200 cases, we get just around 2 cases of anaplasia. The third is nephrogenic rest. very rare. As the article said, that about 30-40% of cases, especially for WIM stage 5 bilateral. But here, around 200 cases, we get rare, cannot over 4-5% of the nephrogenic rest, really low ratio. That means something different. So I think around 1 year more, we will finish on that number and may give at least something new to COP in the article. Yes. Yeah, sure. We try.
No, no, it's very interesting, the epidemiology of everything. There is also one thing that when you biopsy, you do a sample. And I know that our pathologist said, okay, on the biopsy, you don't have blastema, you don't have anaplastic cell. It doesn't mean it's not anaplastic and doesn't mean it's not blastematous. So also the treatment change after surgery. So this is one of the factors also why we do not perform biopsy, because the important thing is the surgical piece when the pathologists have all the piece to be sure and adapt the treatment in consequence. But I can understand if you don't have the same percentage and type of hate, it can be interesting to know.
Yes, it's a long discussion and very helpful for us. Yeah, now we will now move to the last session, last lecture this morning. Dr. Naila and Dr. Baskan will present the lecture, Why Should We Never Operate a Tumor Without a Diagnosis in Children? Please.
So you ask us to debate and why should we
Never operate.
it's a mistake. So, sorry. Never operate a tumor with. Non, c'est pas celui-là. C'est celui-là.
Si, c'est celui-là.
Okay. Sorry. So we should never operate a tumor without diagnosis. So we are. Sorry. A couple radiologists and surgeon to present this case. So what is the worst nightmare for the oncologist and the surgeon? We think that it's a misdiagnosis, spillage or rupture of a cancer, incomplete resection, aggressive attitude for non-solid tumor, inability to assess to treatment response, and redo large surgery. So we think that it's a nightmare for us to have this for the oncologist and for the surgeon. And a good practice, what is a good practice? It's a good imaging, a good evaluation. Alors, ask for the radiologist and of course try to find an oncologist who like oncology. So try to have a nice friend who like to see CT scan on Friday night, CT scan early in the morning. So you have to find a friend, and of course in radiology, a good clinical examination, maybe it was the first item. Tumor board meeting or discussion surgeon radiologist anyway. If you're in hurry, it's a Friday or weekend, and you have to discuss with a radiologist. Biopsy or in a fine needle before surgery if needed. So we debate a lot about biopsy, I know. Samples sent to molecular pathologists. It's very important because the surgeon, because sometimes they make the biopsy and not the radiologist, and they want that the material is is used the good procedure. So frozen, not frozen, in physiologic serum, you ask, but please don't put in a formaldehyde because probably what pathologists say, I can't say anything. So So avoid worsening for the event-free survival or overall survival. So it's very important to have this point of view, and I'm sure that you have all this point of view. And
okay, so we're gonna show cases and see where went wrong and what could have been done to be better, to do better. So the first case was a 16-year-old boy who presented with a pain and a lump in the right chest. He came to his surgeon. He told him, okay, we're going to perform an MRI. And this is the MRI of the... And this is the MRI that was performed. And when you see the MRI, it's really scary. You have a lot of edema in the pectoral space. We have a lesion that is heterogeneous, maybe necrosis. We don't know. It's a lot of contrast uptake. It's scary. But so the patient was sent to the radiography, and if you do the thing like and follow the good practice, you start with good clinical examination. The patient had a trauma like a week before. He had pain, and then the pain disappeared and the lump appeared. So to be good, the first thing to do in soft tissue mass is ultrasound. It's not MRI as first step. So we perform an ultrasound. And at the ultrasound, we can see that the whole lesion is calcified. So we said, okay, maybe it was not necrosis. Maybe the heterogeneous aspect was calcification. So we performed a CAT scan, because it's a hard place to see on X-ray. And at the CAT scan, on the TDM, you can see that there are a very smooth, linear peripheral calcification inside of this lesion. And that the edema resolved a little bit between the MRI and the CAT scan performed 10 days later when the patient was sent to the radiologist. And here, when you have a little bit of practice in soft tissue tumor, you can recognize a lesion that is characteristic with which is ossifying myocytic, circumscribed ossifying myocyte. So you don't have nor to perform biopsy, nor to perform surgery. It's a self-resoluting lesion. And you just say to the patient, okay, have some rest, and it will go away in a month max. So this is very important to, as for the surgeon and for the radiologist, to talk about the cases and to be able to perform a good first imaging and to not perform maybe MRI if we can start with ultrasound, so it can help the patient to avoid surgery or unnecessary biopsies.
This is a case too, a 15-month girl, and the parents was asking about a solid mass on the labia, on the right labia. So it was a small perineal mass of 2 centimeters indolent with this echography. So this ultrasound examination show that it was a tissular lesion, vascularized, and it was not fat or cystic lesion. So, l'animation, elle est partie? Il n'y avait pas une animation? So, small mass, ultrasound examination, 3 centimeter well circumscribed vascularized lesion. What could it be for you? I ask you.
Do you think it's benign? Do you think it's malignant?
Laissez un peu. What could it be?
At least benign malignant, if you don't have a...
It's a tumor for you?
Yeah.
It's a benign lesion? You think? So it's a vascularized lesion. And she's 15 months old, and it's in the labia. You ask for some, so you want to resect? You want to do something else? Ah, Babsi. Yeah. So we ask surgery, biopsy, follow-up. So we ask, and the surgeon resect the lesion. So without any imaging, no other imaging else than the ultrasound examination. He resect the lesion, and the pathology was alveolar rhabdomyosarcoma, and she was R1. So sorry for that. So new evaluation, CT scan, PET scanner, MRI. So Leila.
Yeah, so on the evaluation after surgery, so we don't have residual visible tumor in all the post-surgical aspect that we have on the labia, so we don't know if there is something, but we found a lymph node in the inguinal area and in the iliac area that are also highly FDG avid. And I told Pascal, like, do you think this one is palpable or something? Because I can see it. And Pascal told me, yes, it was. So if we have maybe perform a good clinical exam at the first place, we could show that this mass was not isolated. There were lymph node associated with it, so we would be more careful. And I took a biopsy of the ganglion to confirm the N1 stage. And after chemotherapy, we perform a new TBM. We put chemotherapy. We had a good response, but not all was clear after chemotherapy. And then was the time of the surgery.
To redo surgery for the labia because it was R1, so we had to do surgery on this location. And we have also to do lymphadenectomy, a large one. It was also on the inguinal area. So we need to do lymphadenectomy here and here, and to do surgery on labia. So I found many lymph nodes at the time of the surgery. And I resect also on the labia, so on the vena cava, on the iliac artery, on the superficial lymph node also. So many lymph nodes. And so we prepare her for brachytherapy in case of invasion of the scar of the labia. So we prepare in case for brachytherapy in this site, and maybe radiation for the lymph nodes. So we prepare the plan in case of the pathologist will say it's positive on the labia because of, but we didn't expect so much lymph node as we found. So, and il manque quelque chose. So, okay. So, at the pathologist said it was still viable cells of rhabdomyosarcoma in the labia, and lymph nodes were all invaded. So we have a field very large, and we asked Sylvie for the irradiation, and we had a tumor-borne meeting with the radiation oncologist, and I can ask Sylvie to answer.
Tumor-borne meeting with radiation oncologist, with radiologist, with surgeon, with histologist, and finally,
Pediatrician.
pediatrician, yes.
Oncologist.
Bref.
Psychologist.
And we decided to do not brachytherapy because there is lymph nodes involved, but external irradiation, very localized external irradiation with the irradiation of lymph nodes. So it was quite large irradiation for this very small child.
And I had to do further transposition of the ovary because of the irradiation, of course. So if we want to analyze the case, what had been done, what should have been done, and remember, small mass with ultrasound examination, and Nela said it was vascularized, and the resection is not logical because when you have this case, you have to be more precise and to have discussion with the surgeon or the radiologist. Maybe not TBN at the beginning, but at least MRI and further ultrasound examination of the abdominal location to find if you have lymph nodes, if too precise. Is that correct, Nela?
Yeah, and when we discuss, maybe sometimes, like in the case before, the radiologist can perform a diagnosis without anything, and sometimes going to say, okay, you're right, I don't know what it is, so we have to do, and we have to do. And this is why we can delay surgery when not necessary.
So as you said, you should do also good clinical examination.
Yeah.
Yeah.
You will find the lymph node. This
Yeah.
is another history.
Yeah.
Yes.
Yeah.
Of course.
So if we, after the CT scan, MRI, we had the TBM, we should have decided, we decide to make biopsy of the mass and discovery of alveolar rhabdomyosarcoma N+. And we should have done chemotherapy first and then surgery of labia, complete resection probably with margins. Because, yes, no, it's a hypothesis. So if you know that if you have a rhabdomyosarcoma, after you need to have safe margin.
Yes, it says margin positive.
No, it was with safe margin, the more importantly, safe margin.
Okay. So after we should have discussion of lymph node, of course, because lymph node after chemotherapy, we have the pathologist, we have the final word.
And as you can see, we will not have discussed the irradiation of the labia. So it's also a smaller field of irradiation and a smaller, less sequelae for the child.
That's a little bit. Okay.
Okay, now this is a sad case. It's a 17-year-old boy who presented with a lump in the thigh. He said it was maybe there before, but really growing over the past 5 to 6 months. And he had like neurological pain. So the surgeon asked for an MRI, which was a good thing here. And you see this lesion, which seems to be on the way of the sciatica nerve, and was well demarcated, no necrosis. Okay, so in the differential diagnosis, most probably it's like a neurogenic tumor, but it's really big. And second, it was growing over the past 5 months, so maybe we should remember that before what happened next. So the surgeon said, okay, you tell me this is a neurogenic tumor, probably schwannoma or thing. I'm going to operate it by enucleation, simple enucleation and preserve of the sciatica. The surgeon performed a morcellated and incomplete surgery because it was enucleation. And then we discovered that it was an MPNST. And I think there was something in the clinic, MPNST, malignant peripheral nerve sheath tumor. And as you all know, sarcomas who are morcellated and not operated well are very worsened. The prognosis, the surgery is very important in soft tissue sarcoma. So when the surgeon at the beginning doesn't perform a good surgery with safe margin, with everything in unblock, everything, it worsens a lot the prognosis of the child. So here, later after, we saw if he had what he had left, and he had left a macroscopic residue. And he had at the staging also pulmonary nodule. We had a TBM. We thought of what do we do? Do we start chemo? Do we reoperate? Do we redo surgery? We started with chemo because to let the child a little bit rest from his sequelae of the first surgery. And in the waiting of the surgery, because you know MPNST does not respond well to chemo, it's very, very bad prognosis. The patient had a progressive disease and died. So, okay, it looked like schwannoma, it looked like everything, but maybe if the radiologist and the surgeon have talked about the case, the biopsy was easy, the lesion was big, we could have performed biopsy, knows that it's an MPNST, and have a good surgery later on, and maybe not. So again, when you have those things, discussion between radiologist and surgeon can really save lives.
This is a 15 years old girl with complaining of abdominal pain, and she had a tumor, a pelvic tumor. As you see, and Nayla can describe this lesion.
So first ultrasound, but we didn't put it because MRI is more easy for everyone to understand. So we had a lesion from the right ovary, as you can see here. There are some parts, as you can see here in white, in hypersignal T2, who are really cystic. There are some other parts, like in this T1, who are hyperintense in T1, but maybe hemorrhagic and not fatty. And some solid component who are who has the contrast uptake after gadolinium injection. You have also some fluid in the abdomen. And here you can see, but it's not visible, maybe some beginning of spear torsion. But she was not, at the time of the MRI, she was not in pain anymore. So we planned, I told to Pascal that there is a lesion. It may be a germ cell or not, or anything else. And we're gonna assess and plan for tumor markers, and then we'll see.
So the markers were alpha-fetoprotein, human chorionic gonadotrophin was negative. And she was complaining, so in emergency, she was operated with a torsion. As you see, there's a torsion of here. This is the torsion. And after the torsion, the ovary and the tumor was nice. So considering that the markers were negative, the surgeon for mature teratoma want to do conservative treatment to keep ovary. So the surgery was conservative procedure with keeping a third of ovary, and the no spillage, and the pathology say granulosa tumor. And after the markers of inhibin B was done, and it was elevated, not so elevated, but elevated. So we could have done the diagnosis with the elevation of inhibin B. So there was an international TBM for this, and they recommend to redo surgery to make the ovarectomy. And the pathologist said the ovary was okay. But this is a discussion. So if we analyze the case, what should have been done? Probably when you, at the imaging, Leila noticed something she could say to you. There was no fat on the component of the tumor. So probably you can have a cystic lesion, of course, with a teratoma, but you can also be suspicious when we have no fat, and you have to ask for the inhibin B. It's exceptional, but in the good procedure, all the markers will be alpha fetoprotein, RCG, and inhibin B. And waiting for the marker, of course, surgery would be not conservative treatment. But there was a torsion, okay? But
yeah, so here we have, I don't know if in Vietnam you have the same epidemiology, but mature teratoma are more frequent than granulosa tumor. So the radiologist see a big lesion who is heterogeneous and everything. He can say, okay, markers alpha feto beta HT for germ cell tumor are negative, but we have always to think of a differential diagnosis. We are not pathologists, who are radiologists. It's different specialty. So we have to think it may be germ cell because it's more frequent, but it may be non-germ cell, and look for other markers for non-germ cell. And if, as a radiologist, we didn't think of it, we have our colleague, when we talk with them, they say, okay, do you have fat? No, I don't. Do you think it may be non-germ cell? Yeah, maybe, it can be. Okay, so we're gonna ask for other markers. And then maybe when, even if she was in pain after and she had torsion, detorsion, at the time of surgery, she could have, the surgeon could have performed the ovarectomy at the first place. So we always have to keep in mind that there are multiple diagnoses for a mass, and it's not only one.
If I may report some other events that we had with a younger lady with a smaller ovarian tumor. We were not taking into account the fact that this other younger lady who had a ovary tumor, heterogeneous, had 2 weeks before an amidalectomy. And this amidalectomy was discarded, was not studied. It was 2 weeks before. And when the tumor was taken, there was no torsion, there was no marker, nothing. It was in 2006. I remember the case. The ovary was taken, it was a Burkitt lymphoma. So inside the differential diagnosis, you can also pick in the story of the patient something that tells you that you should not be too courageous in taking the ovary, and listen to the story of the patient.
So thank you for this particular case, very interesting. Firstly, is a mass, but according to your experience and my experience, it does not look like a mature teratoma. No fat, no calcification, and the cystic fluid is very small. And most of there is a papillary structure and solid structure. So I think you have suspicious about other tumor first. But I have one question. This is because you must pain and torsion And this can be diagnosed in CT scan, that is the torsion, and you have to do emergency. So maybe in case emergency, maybe not all tumor marker is ready for you. So what should be done as a good practice? So just the torsion and wait and see, or you should do intraoperative biopsy and something, I don't know. No, I ask. Or is safe, like you said, just leave the ovary and then do the old marker and then come back to surgery again? So what do you recommend?
Yeah, usually in the course I do on Friday, I recommend if you have torsion and you have no markers, nothing, you make the detorsion and you wait for MRI and the markers. In this case, particular case, she had a MRI before and she had the markers. She came outside another country with complete diagnosis, and she made the torsion between the result of the inhibin B. But I agree with you. If you have torsion and you have no markers, and you have because with your experience, you see that you have voluminous tumor with no fat, you have to be aware and say, I wait, I just make the torsion and I wait for the
So
no, but of course, no biopsy.
Yeah, we do not biopsy the ovaries because the risk of
spillage.
spillage
Okay.
in this case, and there are a lot of cystic component and everything is too high, and it's intraperitoneal, so no biopsy. But yeah, well, tumor markers.
In this case,
No,
it has
it's
negative.
okay.
LDH, we do.
I have just a bit.
But because this is 50
a remark.
years old.
Just a remark. In this case, if you have when you do surgery for conservative surgery in ovary, when you remove the mature teratoma, in case you have just immature in a side, you have to be careful, not spillage. So you find the plan between the ovary and the tumor, and you be careful of that. And in this case, there was no spillage. So the surgeon is doing well, because pretty good, because no spillage. So if you are able to do that, considering this case, we have no face attitude. It's quite correct, but this case was very interesting to recommend to do the markers, to do the CT scan, and to have a good analysis with the radiologist to say there's no fat, it's strange, something like that. So you have a discussion.
One more question. In this case, why did you do open surgery?
No, it's a large tumor.
The same. Like
No.
I can do it.
No.
Anesthectomy.
No.
Put it in the back.
Yes, anesthectomy. But when you do conservative treatment and for the ovary,
This is
over
malignant.
over 5 centimeters. I do under 5 centimeters. I can do in laparoscopy to find the plan between the ovary and so on and so on. Okay, but over is not possible. So you make spillage, you make something wrong. So you have to do fan and steel to do it.
For malignant tumor, I prefer with margin, not. I'm not say about conservative, yeah.
But you know,
if you know that, they're like
yeah, you're right. For malignant, this is why we perform ovarectomy after, because the recommendation is.
But now you already know the diagnosis. Why do it open surgery? That's my question.
No, because the diagnosis was false. Because they thought in the other hospital, and they came to the surgeon, they thought it was mature teratoma. And the girl came with torsion, detorsion, and they thought it was mature teratoma. So the surgeon came to the surgery with the thought he was operating a torsion over a mature teratoma. This is why we said no. If
It's
you look at the
a
MRI,
key case.
it was strange. It was not mature. We didn't have all the markers. So yeah, detours, wait, and
Okay.
So
This is also started.
sometimes we have some of the case, the newborn, the newborn, and diagnosis the antenatal in the teratome, and after birth, the patient come to my department. So the tumor not too much bigger and 3 centimeter. So alpha photoprotein tensor level, tensor level. And imagine they saw that the tumor. So I'm not sure the tumor benign or malignant. So in this case, usually I can to do the operation to the cut and biopsy into the operation for the diagnosis or no?
No.
no,
Don't need to do.
you never biopsy an ovary.
No, biopsy and operation to
Nhưng mà em cắt
biopsy
trứng.
into the operation.
All, not in the
No, no.
operation, not percutaneous. You do not biopsy.
Because
We
I'm
don't-
not sure the tumor teratome benign or malignant.
Yeah.
For neonatal period, he said.
Yeah.
She says.
No, neonate,
the
we don't have.
Diagnosis was done antenatally.
Yeah.
No,
You
Yeah,
Yes,
yeah.
okay.
attends.
In my department, because I diagnosed it antenatal, and after birth, the patient come to my department.
Je veux dire ça. We have immature teratoma, but we don't have malignant Yeah, but we don't have malignant tumor at the age of neonate. After.
Yeah.
Thế thì em cắt cả buồng trứng luôn, không bảo tồn đúng không?
Mais-
Các buồng trứng không bảo tồn.
Ồ,
Mais c'est pas pareil.
đấy.
Tại vì là nó là immature.
Không, làm sao anh bắt chưa được?
Alors,
Về sau kết quả thì có bệnh.
on va
c'est vrai.
oui,
Có bệnh của em.
we continue. We
Vì một
continue.
cái dễ nhất mà họ nhấn mạnh ấy, mọi người để ý. Chỉ cần
Just one,
CT thôi.
please.
Chỉ cần CT lên là có tổ chức mỡ. Khi thấy tổ chức mỡ và cái CT nó
We have the surprise case. Okay.
Okay.
Just for the
Okay.
fun.
Okay,
To
just-
finish.
Okay.
Surprise case, it's 4 years old girl. And
Non, c'est avant ça.
merde. Pardon.
Oh.
So 4 years old girl,
Oh.
palpable mass on the left flank, high blood pressure, uncontrolled and thrombocytopenia. And she had
She had an ultrasound and a CT scan that you all see here. In the CT scan, you have a lesion. You can see the kidney here, and you don't, and here, and you don't see the close sign. So we think that the lesion is not from a renal origin, and it's not from splenic origin. And we're okay, so maybe it's retroperitoneal between the kidney and the spleen. So maybe at that age, adrenal tumor. The pancreas was really in contact with the mass, but really move forward that we cannot see if it's pancreatic or not, but it's rarer to have a pancreatic tumor. So we said maybe most frequent probability is that it's a neuroblastoma. So we would have performed MIBG, but at that time we had a problem with our machine. So it was not working. So we performed the TEP Doppler. And at the TEP Doppler, you can see that you have a small, not a very high, but a small uptake of a part of the lesion. So we said, okay, maybe it's a neuroblastoma. And then we started one course of chemotherapy because we did not perform biopsy, because as you saw, very high blood pressure, uncontrolled high blood pressure, and very high thrombocytopenia. So the biopsy could have led to hemorrhage and everything. We said, okay, it's a big tumor. We're going to start with the course of chemo because we have the TEP Doppler and everything and the probability. And when the child is a little bit better, we're going to perform the biopsy to confirm the diagnosis.
and surprise.
Surprise. It was the biopsy came back Burkitt lymphoma. So we performed a good imaging, which was TEP FDG. And here you can see it's really high uptake in the TEP FDG. Thanks, it was localized and no metastatic disease. And after the good chemotherapy, it shrank a little bit.
But we have still a large mass. And what do you think about the origin of the mass?
Yeah, because Burkitt lymphoma.
An idea?
Radiologists. So if it's not the adrenal, from where it can come from?
No,
No.
no, no.
No. Yeah, the spleen was higher. You can see it on the slide before.
Ah,
Here.
yeah. Pancreas. Never seen.
Yeah.
Yes, it was pancreatic lymphoma. It's very rare, of course. It's a surprise case, I said. Okay. So I had to remove a part of the mass, and of course, don't be extensive because it was the pancreas. And remove about 90% and it will necrosis. Okay. But it was large, so we decided to do surgery.
Why this patient received CYBB? It's because of non-response or because of previous treatment with
Non, mais
evaluation of
non, bah c'est bien. On lui racontera après.
Arrête. Non, mais.
The reason I see for this patient to receive stage C, stage C protocol is because it's probably a stage X, because you were not performing the complete evaluation, after before.
Okay. Thank you.
Thank you.
Oui.
So thank you very much for very interesting cases. I think very chúng ta thấy là ung thư đúng là khó, đúng không? Ngay cả bên Pháp hiện đại như thế mà nhiều khi họ cũng có những cái lỗi mà họ thấy nhìn lại là vẫn có vấn đề mà mình sót.
For the case. I was in vacation, in holidays, and he called me. Il s'en remet pas de ça. C'est pour ça que j'ai eu le cadeau, je pense. À la vie et à la mort. C'est vrai. Yeah, I know. We decide to do laparoscopy to see the environment and no carcinomas, and decide to transplant. There was a discussion. Yeah. I remember. Yes, during my vacation. I was in Brittany. Yeah. Mm.
Yes, thank you. And now we have about 10 to 15 minutes left. So we would like to introduce two cases with the missed. Yeah, it's very interesting case.
Tu râles. Puis avez-nous une photo? C'est pas le bon document. C'est pour ça que j'ai cliqué quand j'ai vu la faute. J'ai dit c'est pas le bon. Tu sais qu'ils aient foutu de moi. C'était vrai.
Michel, des équipes françaises, mais moi, aujourd'hui, l'après-midi, quand je viens à l'université de Saint, l'après-midi à 1h l'après-midi, mais je veux accepter toutes les équipes en vendredi après le cours ici. Mais moi, encore, c'est intéressant, mais la même aujourd'hui. Je présente en vendredi et après, je vous invite à toutes les équipes prendre le pas de manière avant d'aller à oui, avant le voir et l'après-midi à quelle heure?
I have to leave also. Thank you very much.
See you again. Midi à 18h, on fait du shopping, nous. C'est ça, hein? Si j'ai bien compris. Hein? On dit quoi? On dit... Fait... Midi? 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 Ouais? Midi? Nice. Merci. 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 Ah.
Dr. Trân
But they want
dans
to present two cases of the...
l'université.
Ah, ok. Ah.
Ouais.
Allez à l'université.
Le doyen.
Bah, j'espère à bientôt. Alors, à bientôt.
Merci beaucoup. Ouais.
On essaie de collaborer.
Merci beaucoup.
À vendredi.
Merci beaucoup.
Merci.
Ouais. On va voir bientôt. Oui. Chị Lan làm nốt nhá. Đấy, hôm nay.
Il m'a rappelé, dans son bureau, là, quand tu m'as fait un cadeau, il m'a rappelé le malade. Et alors pour lui, j'ai sauvé le malade. Parce que tous voulaient lui enlever la tumeur. Et j'ai dit non, il faut le transplanter. Vous n'arriverez jamais à enlever cette tumeur. Et il me dit, bah... Et alors du coup, j'ai dit, faites une laparoscopie pour vous prouver les choses et puis voir, être sûr qu'il n'y ait pas de carcinose avant, évidemment, de...
Yeah, sorry, we can...
Ils ont pris le foie de la mère. Mais c'est bien passé. Il va bien.
We can start. We can start now. Yeah, we can both eating and listening. Yeah. Yeah, the first case of large diffuse B-cell lymphoma.
Hi everyone, I'm Dr. Cường from Oncology Center. This morning I present a case of large diffuse B-cell lymphoma and HBV infection. Yes, my patient years ago, 8 years ago, clinical presentation of diagnosis abdominal pain. Medical history, the patient had diagnosis chronic hepatitis B for 4 years, and she untreated. She starting treating with entecavir from June this year. In August this year, she has been detected mass other spleen on ultrasound and has been followed up at the previous hospital for months. Size much increased on CT scan and referred to VNCH. At diagnosis, abdominal CT spleen was normal size and mass of parenchymal spleen mass about 4 cm with smooth margin and well-defined border. In theory, we suspect that this match could be a hemangioma aspirin. And then we decided splenectomy without rupture. She splenectomy without rupture in September this year. Clinical examination at the second admission, he see no respiratory blood pressure normal and no hepatomegaly, no lymph nodes. While waiting for result of pathology, she has vomiting. We suspected brain spinal massimo and bilan for metastasis. Pathology of tumor aspirin is a large diffuse B-cell lymphoma with negative surgical margins with CD20 positive. Maxillofacial MRI is a nasopharyngeal mass about 4 and 5 centimeters invading the right sphenoid sinus and cavernous sinus. Spinal and brain MRI is no secondary lesion. Chastity and abdominal CT is not normal. Bilateral BMA and CFS is normal. We diagnosis large diffuse B-cell lymphoma in spleen with CNS positive. She was treated with CCZL non-Hodgkin lymphoma guideline group C1 with CNS positive from September this year without rituximab and continue entecavir. We treated COPE and brain MRI after COPE. The tumor decreased inside about 65% with investing of the rest sphenoid sinus. Then the patient continued treated COPAP-1 without rituximab. After chemotherapy, she was fever and neutropenia, enteritis, and we continue treat antibiotic as protocol. About HBV infection, the family history, the mother with untreated chronic hepatitis B, and maternal grandfather with HCC. On June this year, he starting treated entecavir, and she didn't perform drug resistance before treatment. The summary, this is a girl 8 years old. Surgery in September this year, complete resection of the tumor and spleen. Pathology is large diffuse B-cell lymphoma with a CD20 positive. Maxillofacial MRI got a nasopharyngeal mass about 4 centimeters. Chronic hepatitis B with treatment entecavir for 3 months. We treated COPE and COPAP-1 without rituximab with CCZL non-Hodgkin lymphoma guideline group C1. And after assessment after COPE-1, the tumor in reduct inside decreased inside about 65%. I have a question. This patient didn't have any clinical sign, cruise abdominal pain and ultrasound and finding relief mass aspirin. How should we approach the diagnosis? Thank you.
I have one first question about these patients before I try to answer your question, because I don't know if it's easy. The first question I have is, you stated that this patient is CNS plus. Is it a parameningeal disease or is it a positive CSF?
Adenosis on maxillofacial MRI.
So you saw
station.
the cavernous invasion. The cavernous sinus was invaded. This is a reason to state this is a stage, stage
Yes.
C, a CNS tumor. Is it a reason?
Yes. On MRI, the tumor invading the sphenoid, synod, and cavernous sinus.
Okay, good.
Yes.
That's a reason. But the CSF was negative.
CSF negative.
You know, because hello, radiological friend. I think that so I agree. Then, even with CSF negative, you consider it stage C, and because you don't know where is the egg and where is the hen, because probably the primary can be also the sinus, and the other localization is the spleen. So I think that, trying to answer your question, I think that since you had the only signs you had to find in this patient was the spleen abnormality, this is the way to do, because we don't like to make a biopsy of the spleen. We don't like so much. Yeah. I think it is probably the best way to make the diagnosis, to have the splenectomy done. It's unfortunate because if you have known before that there was something in the sphenoid bone, you probably would have done and asked the surgeon to do a biopsy of this. My concern is that you were treating this patient using the LMB Fab 96 protocol, the regular arm, the reference arm, which is COP, then COPADEM 1, COPADEM 2, probably soon. But you are not using rituximab. Is it because of the HBV infection? Is it the reason?
Yeah.
So
Yeah.
you mentioned you had the discussion with your hepatologist and they said that it's not good to give rituximab. Is it the reason?
Yes, the patient is have a hepatitis B virus. Is if they use rituximab, so we have a balance the active hepatitis. Yes, then
Yeah. Okay.
Yeah.
Okay.
This
So
copy virus copy very high.
okay.
Now she's receive encyclopedia.
Entecavir,
Yeah.
I saw. Because it's because of HBV that you didn't give it.
Yep.
Okay. Because you know that the results are not as good in CNS positive disease without CSF when you do not use the rituximab. So you had to balance the risk and the benefit of acting that. And so I understand better. I think that probably for this patient, you will have just a little difficulty to decide if the patient is in CR at the end of 2 CYVE, because you will give a second COPADEM and you will give the CYVE and CYVE, but at the end of it, it's likely that you will not have a complete recovery of the sinus disease, and probably, but you were not doing the PET scan at diagnosis. But it would be nice in such a situation to have, since you are going to have a difficulty to make the biopsy, to make sure that it's a CR at the end of CYVE. It's probably good to have a PET scan at the time of the end of induction. So you have COPADEM 1, 2, CYVE 1 and 2, and then evaluate with a PET scan. Although you had no PET scan at diagnosis, it's a good option to verify the CR situation. And my last question, maybe it's probably to TAC. You don't know still in this patient if this patient had EBV genome in the tumor cells? Did you do the Eber thing, RNA? Yeah. Okay, so because you can also do the LMP protein, which are very positive, which are an indirect evaluation of EBV positivity. LMP1, yeah. Yeah. Okay. Okay, so you have it already. Yes, it's more sensitive. Yeah. Okay. Good. So because in this situation, I think it's although this is a massive infection with HPV, so there is no much doubt about the fact that this is not a surprise that this child, this 8 years young girl, has an HBV infection with a grandfather who died of HCC and a mother who has an active HBV infection. So this is normal, I say, normal that she has HBV infection, because otherwise I would have been interested in looking at the possibility that this patient had some kind of deficit, immune deficit, explaining both HBV and EBV, but if this is an EBV actually. So I think that at the end of the treatment that you will give without rituximab, it's going to be interesting to look for immune function in this patient, to make sure that this patient has normal lymphocyte counts after the end of chemotherapy, because probably I think it's wise to look at that, to look at immune function. Okay. She is on penicillin, on prophylaxis. Is she on prophylaxis for after splenectomy? Oh, okay. I think you probably should think about it, because after splenectomy, she's exposed to overwhelming pneumococcus infection. Yeah.
On a sound file for fire nodule in the spleen. So after that, patient have an abdominal and on abdominal five hypodensity or nodule in the spleen around the artery, posture and delay. Yes, abdominal CT, we find a hypodensity lesion in the spleen. It hypodensity on throughout the face, arterial face, portal face, and delay face. So we think it could be a hematoma, not a hemangioma. So because of this diagnosis, so we go straight to the surgery. And after, yeah. Yes, because we think it's hamartoma, so we don't do MRI. But after this case, we have experience. And for the next patient, we do MRIs. And on MRIs, we have a diffusion sequence. And on diffusion sequence, we can see the restrict diffusions or not. It can have differentiations between the malignant and benign.
I totally agree with the first most probable diagnosis. I would have said the same, but because the clinical impact was splenectomy, and it's a big surgery and a big consequences for the child later with the vaccine, with the I think we would have, even if we think of hamartoma, performed MRI just before, because splenectomy is still a big surgery. It's not nothing. So I think we would have performed MRI before, but we have to learn. Also, we all did this one, right?
So the reason you did surgery was what for the surgeon? Why did you perform splenectomy? It was to have a diagnosis or to remove a tumor, a benign tumor, because you think that it's fragilize the spleen? Because we had the same case a few months later before, and we asked everybody why we removed the spleen. So we search for sarcoma, we search for lymphoma before removal. So because it's not a little surgery. It's a little surgery, but the consequences are a kind of could be not so good for septicemia, and because she was young. So what do you think, surgeon? Because you are responsible of the.
So yeah, I'm not a surgeon of this patient, but the first before the operation, we think that it is hematomas.
So why removal? Why?
And the patient have symptoms, abdominal pain, and it
Pain.
repeats for pain, and it repeats for several months.
Okay.
And
Okay.
and we planned to perform it through laparoscopy.
Yes, I know,
Yeah.
but okay, because we had the same case, but we were looking for some reason not to remove the spleen and search another pathology, so lymphoma, sarcoma, low-grade sarcoma, and many things. I don't know. Maybe. So the pain was the reason to
Yeah,
remove.
the question was, do you think the pain was related to does hamartoma causes pain?
Yeah, because it repeats several times, and the and it means we find we have no answer for other reasons.
Yeah. Okay.
Yeah.
Okay.
This is too bad that she had headache after the splenectomy.
We have another splenic tumor just after this stage, and to have a lesson and experience, and I do and write. Would you like to see it? Just after this. Yeah. 1 minute or 1 minute.
Do you present the story first? The story first before the X-ray?
This day I shall discuss tomorrow, so I will leave it tomorrow. Okay. Tôi quay lại mình lấy thuốc của con không?
Ôi là chưa đến giờ.
Ý kiến của chị là như nào?
Hả?
Chị ạ?
Em đang đấy. Chị tưởng nãy giờ share rồi chứ chưa? Chưa có tiếng. À, chưa có tiếng à? Không phải là chưa biết. Vẫn đang bị có lỗi không? Nó có nhìn thấy này đâu.
Ca này mổ của mai này đúng không?
Đúng rồi. Mổ à? Mổ là cái này sinh thiết chưa? Rồi, chuẩn đoán rồi.
Hóa chất rồi.
What else? What else? Do you have something about the sphenoid bone or something like that?
Chị đọc về phim
Do you have an extension? Did you check the bone marrow, the bone
Chuyển được cái
of this patient?
xương.
Yeah, and how is it?
It's normal.
It's normal.
Một màn hình.
Nothing.
No, brain is not normal.
Maybe it's the same.
Cộng hưởng từ mình chỉ
Không được,
mỗi não thôi đúng không?
sâu cái slide đó ra.
Exceed homogeneous localized dural thickening at the temporal and frontal region along both.
Này. We have a brain MRI.
Yes.
We will show you.
Con marrow thì bình thường. Mai sợ được không?
That's not a normal suit.
Chấp nó gửi ạ.
Chị hỏi đấy.
Hay là ở Zalo tôi sẽ nhìn thấy thôi đâu. Đây, để mình không đây. Đây. Của trẻ em lên sâu.
Thì cần nhìn đâu nhỉ?
Zalo hay là
Chắc là bằng cứng à? Cho tôi ra đây. Không để
gửi ico lên, gửi ico chỉ có ico cũng có.
Chị chỉ cho ông cái chỗ mà chị nghi ngờ ấy, vì lúc đầu chẩn đoán là di căn nở ở xương sọ.
Xương sọ.
So, nothing.
Coronal flare xem nào. Coronal flare. Làm sao để bảo cái này đi vào được? Đẩy nó xuống được không? Cái cửa sổ này nó bị lấp. Em ơi, cái thanh công cụ này nó bị lấp cái thanh công cụ. Chị muốn lấy được cái chỗ này không ra được à?
Thì em lấy thôi.
À đây cho hình to lên vậy. Đây, hình to lên. Không cho. Vẫn ở xa.
And so what do you like to do to discuss this case?
Đó. Xương sọ trên cổng tử à? Mình có chụp CT cái sọ không ở với anh?
Đã.
Mình có chụp CT cái sọ không?
Không, chỉ chụp MRI thôi ạ.
Cái này đọc tổn thương ở đâu?
Ở cái bằng cứng gần với cả
bằng cứng chứ không phải xương.
Nhưng mà chị đang xem có phải phim đầu tiên không hay chị xem phim sau?
Phim sau gần nhất.
Không, chị xem cái phim đầu tiên.
Phim đầu tiên gì? Chị nhớ là cái đứa này lúc đầu mình dùng nhắm 90
Vâng.
phải gì? Hay là sao chị cứ trông lại bình thường? Nó có hai cửa sổ thì nó sẽ ra như thế.
Em không biết
không.
Tức là cái tổn thương sọ không?
Bình thường. Sọ không phải. Cái lần này là thế. Lần xa nhất này. Lần xa nhất hả?
Lần đầu tiên em chẩn đoán đấy.
Em chẩn đoán.
Đấy.
Lấy cái tên ấn được.
It's 2 months ago.
The last time of brain MRI, we see no lesion on the dural.
The first one.
The first time, yeah.
So because this patient was born.
Lấy cái tên thuốc luôn đi.
September 2024. And the first examination was in May this year.
Yeah.
The first bone evaluation of the skull. Because on the PPT it says that there is something in the sphenoid.
Yeah.
Or what does it say?
You can hear the
It shows the slide, the summary.
Dural thickening. Okay, suspicion of secondary lesion. So it's a stage M below the upper one, but no bone marrow disease, no liver disease. Excuse me? Ah,
We are looking at the initial brain.
so
Ça, c'est la personne qui a décrit ça est peut-être en train de décrire la graisse en
okay.
On this image, we see the thickening of the dural above the left orbit.
Can you put this, because it's a 3D on coronal plane?
3D, yes.
Because I'm not sure that what we see is a dural.
Như đây là tài khoản của ai không dùng ở cái phải
left orbit dural.
Nhưng mà hình này nó zoom to lên, nó xấu lắm. Zoom to lên.
Le thickening dural, c'est de l'autre côté de l'os.
Là tài khoản của ai đấy không tổng của mình đúng không? Của chị à? Không biết.
không, nó đã mở sẵn rồi chị ạ.
Rất là sáng nay của ai rồi? Của ai đấy mà sợ? Phải dùng tài khoản của bọn em thì nó mới.
Thì em nắm lại anh.
Rồi cứ xong cái này đã. Đó.
Tức là người ta thử nhưng tài khoản của các bạn nó mạnh hơn, mở được nhiều hơn. Nó tùy từng gọi là phạm vi trường của tài khoản. Mình vẫn mở tài khoản nó nhiều hơn. Tưởng công nghệ thông tin nó
Thickening of the urine.
Quyền, phân quyền.
Non, en bonne forme, il n'y a pas mal de forme.
Ah ouais?
C'était bien de pas.
Là bạn này.
Nên là bản thứ hai.
Còn ông kia.
Do we have a CT?
Jean Nison.
Is there any study on the CT on the bone?
Yeah, let me see.
Because it's a bit weird.
Để cho nó được giấy.
PT sọ đâu chị ạ.
I don't know
Chỉ
if
cộng một từ sọ.
Cái này là CT 64 dãy.
Là toàn thân.
Muốn xem gì nữa? CT và muốn xem CT sọ. We didn't perform CT scan of the skull.
Okay. So the conclusion is that this patient was considered as having bone metastasis on just the fact that there was thickening. Okay.
Yeah.
It's not a big deal because the treatment was necessary for the abdominal tumor. We will see later what's happening to the thickening. And at this age, at stage 4, stage M, neuroblastoma, the treatment is based on Niken status, which is normal. Can be discussed with CGH, but usually this is more based on histology, and the histology is favorable in this case. So you did the treatment. You started with 2 VP carbo, did you?
Yeah.
And what happened after the 2 VP carbo or after the 4 VP carbo? Did you give 2 courses, 3 courses, 4 courses? How much courses?
Continue with two.
So 2 carbo VP and then 2 additional. And in September, what is the story? It's still very large. After 4 courses of VP carbo, and now what is the status of the bone in the MRI at the top here, and what is the status of the local disease? Because you give cadeau after the VP carbo because it was in September. The evaluation was done after VP carbo number 4. Did you give something else?
No.
I'm sorry. Thank you very much.
No, we stopped chemotherapy.
You stopped chemotherapy because you had some CGH results or whatever. What was the reason for stopping chemotherapy after 4 VP carbo?
NCS thì sao? NCS hay SCA nhỉ? Thì hỏi cái châm ấy, mình nhớ rồi. Không, sau đấy hình như có rồi ấy.
Chưa có đâu.
Camera đâu?
Em làm gì ấy? Có cái gì đâu.
Để làm gì?
Có đây rồi, Nguyễn Minh Khang đây này. NCA.
NCA. So
Em đọc lại cái mã.
now you have Mica negative.
Đọc lại
Mica
cái nhớ là có mà.
negative. You have NCA. And what about the bone disease? If there was a bone disease, are you considering it's now good? No problem with the. Can you show us the MRI, recent MRI?
Gần nhất em này đều gần nhất.
Của bone whole body sọ.
No, the
Scalp.
bone, if there is something
Tức là cái MRI của sọ rồi.
in the skull, in the abdomen, but obviously you have this. So
Đây.
if there is a question about surgery,
250.
we need to look at the abdomen.
Chị nổi 00.
C'est quand même important d'être sûr qu'elle n'est pas
241.
Tu as la réponse?
Bây giờ sẽ là cái CT ổ bụng gần nhất và cái MRI sọ gần nhất.
So it's strange. I don't understand very well. This patient was treated first with a group 10, and now you say this is a group 2. You have to decide between the two.
Because we discussed it I have discussed with you in.
Yes, in TBM.
Yeah, TBM. And then Dr. Hervé and you look at the bone.
And they said there was no disease.
No disease.
Okay, so it's nice to know because I did not remember.
Yeah, it's Dr. Hervé talk about the no metastasis bone.
We have only so we are going to look at the primary side now.
And then
it's always nice to have a nice presentation going from the beginning till 1 hour, explaining why it was changed. So it was changed because during a TBM we were discussing with Hervé, and Hervé was completely okay with Nela, who was not aware of this. And she said there is nothing, and he said there is nothing. So there is not anymore a stage M. Was treated with 4-VP carbo with a minor response.
Yeah.
Because only 25% after 4 courses, and now you will ask to Dr. Pascal.
Yeah, because that's TBM. We talk about the tumor is a very not invasive, it's close. Renal vein, and then dangerous for the kidney, and then the baby is small, and then you talk us about maybe wait until November you coming, and then Dr. Pascal into see maybe she's into.
It's nice to recall that.
Yeah, and she's into with our colleague, our surgeon to come by to.
Is there a more recent scan, because it was September? Is there November scan?
No. Chúng ta chưa chụp lại cho đi. Đáng lẽ gì?
We need a new evaluation.
Do you want to take a more CT scan new? Yeah. Gọi nó vào, bây giờ nó đang ở đây mà.
No, but you know, tell us what you think about that, because when you say it's good with that, we have to check if it's still good. But if you tell us this is no good with that, then we can move to another case.
Okay, we have a risk of course of manufacturing.
Nhưng mà tôi cứ từ lúc ý là bạn nhớ
là cái này không phải đây là renal artery thì đây này.
Đấy, động mạch này.
Cái dưới này không phải, cái dưới này là động mạch bệnh mạch sống. Đó, cạnh sống. It's not renal. It's not. It's a paravertebral artery. Yeah.
Coming from
from the upper. Yeah.
Yes. And the vein, it's close to the vein.
Yeah.
Vein.
The renal vein here.
But
IVC here, and aorta.
There is still something around the aorta.
Yeah, 50%.
And there is still something under the the right iliac artery.
Mesenteric artery, the superior mesenteric artery.
Okay.
Okay, it's a celiac. It's a celiac and
So you feel comfortable?
not easy.
It's not an easy, it's not a piece of cake. The risk is to lose the kidney. And not only.
What do you want to see?
Từ năm mổ đến bây giờ mình vẫn đang ở nhà khá đó.
Bằng gì?
Can we follow the outline?
Down the which plane? Sagittal, coronal. Coronal.
Okay.
Yeah.
Because it's numerical,
Yes.
we can leave some residue on the
Yeah.
altar.
Yes. You can leave some residue along the altar as long as you have no problem. As long as you have no problem with other arteries.
Non, il n'y a que la vertébrale.
The vertebral. And you don't care about the vertebral artery? Okay, so now the question is really now that I can understand the story.
We need a CT scan now.
The newest, the latest.
Sáng mai chụp nhưng bây giờ nhưng mà phải sáng mai chụp chứ giờ này không chụp được, không phải gây mê.
Tomorrow morning. Yeah.
Early morning. Okay. Okay. And do you want to program the surgery tomorrow at the end of the morning with the CT scan before? It's quite short.
Yeah, maybe to take a CT scan at early morning, maybe 7:30 or 8, and then after that we look at again.
Okay.
So
Okay.
tomorrow morning I have course of corticosteroid.
Of course, in the morning.
Yeah, you have two lecture.
Yeah.
And after 10, you can perform.
After 10?
After 10.
10:30?
10.
Sarah with Pascal. So we have to see before the tea break. We have to look at the CT scan because I think we have to be relaxed. And yes, we want to see the other case with biopsy.
Yeah.
So please present first. Please present first the case and then the radiographs.
Bật đi. Ca đầu tiên. Thêm một giây, đâu sẽ được.
Are people connected with us?
Đúng rồi, nó.
Do we have people connected with us from somewhere else?
We have online already.
Okay.
Now we into concern some case tomorrow in candidate biopsy.
Candidate for biopsy.
Candidate. Yes.
Candidate.
Right.
Làm trình bày trong lịch sử. Hello everyone. I'm Trân, cây ở neuroblast.
Ra đây ngồi đi, không có thì sợ người ta không nghe được. Không nghe được.
The patient is female and he was and he 4 years old and diabetes. He was admitted in October 2025 with fever and abdominal pain. And ultrasound at a local hospital detect a retroperitoneal tumor, and her medical history were normal. At clinical examination, he was not, and he had no abdominal pain. Her blood pressure was normal, and he had no weight loss and low vomiting, no abnormal lymph nodes. And on the abdominal CT scan, we found the right adrenal gland, so hypodense mass before contrast injection.
measuring about 6 centimeters. After contrast to a mass, it can heterogeneous, and it is contact with the right ventral vein and is suspected to invade the posterior surface of the right ventral vein. Positive, and the chastity is normal. Coagulation and CPC, LDH, renal function and liver function normal. And during the ABA, BMA, and bone marrow aspiration is ending. And as you were diagnosed with suspected neuroblastoma, L2 state with LTS negative, and we will discuss about the plan of corneal biopsy for her.
Can we see only the infected one pains?
Yeah.
So you said it's IDRF was like to see the IDRF.
Sagitan em làm luôn cái làm Sagitan tại vì họ chỉ cần chạy Sagitan.
So 4 years.
Mà nó chạy không sai rồi. Sao bình thường ở nhà mình nó sẽ chia hình 4 mà sao bây giờ nó lại chia 3 nhỉ?
So you have planned to do the biopsy at the same time as the bone marrow evaluation?
Yes. Đấy, nhìn đẹp hơn. Sagitan đây. Bỏ cái này ra. Tiếp về cái này không? Bỏ cái video đấy rồi. Em cho nhỏ nữa. Đúng rồi, cho nó dưới. Đây sẽ gì? Arrange complex activity. Yes. Okay. Dung nhỉ?
Nhìn cái mạch thận.
Cái này mạch thận thì phải cho sang cái động mạch còn này. Không, động mạch là the artery phase. Artery phase.
Chào Win.
Cái động mạch cái gì?
Thiếu được xem tiếp xúc với
thì phải xem cái thầy động mạch.
Yes, there's intimate contact with the liver.
There is a contact with the liver.
Yeah.
But I think that it could be some adherence or something.
Yes.
But with the renal artery, I'm more reassured.
I change the arterial phase. Arterial phase.
It could be operated.
Yeah, I think. Yeah.
You know?
Yeah.
Discussion with between.
Yeah. Clear margin.
Yes, but you. Yes. Yes, you have to do that. The LDH is normal. LDH is normal. Do not have bone marrow disease. This lady is running with no pain.
Vẫn chạy bình thường.
Mấy tuổi?
Yeah.
5 tuổi.
5 tuổi.
Oh.
Yes, there is no contact with the renal artery.
Okay.
So it can be discussed whether surgery, primary surgery, or corneal biopsy.
Cái này mổ được mà.
It can be discussed. If you can't perform surgery or you're afraid of the non-numerical neuroblastoma, we can perform biopsy, but both are correct, I think. Yes.
So,
and it's feasible.
Yes, the idea is that we can do the biopsy, we can do the bone marrow evaluation at the same time. If the bone marrow evaluation is normal, if the biopsy is confirming the diagnosis, it will be a piece of cake for you to do the surgery. Okay, so the surgery won't be done by Pascal because it's not an emergency to take out the tumor. So biopsy, bone marrow evaluation, and then depending on the results, either surgery first, or if bone marrow is positive or bone scan is positive, as a stage M.
Or segment.
Yeah, but you will wait for a while before having the segmental results, you know. At 4 years, this is group 8. Yeah, you will see, because if it's unfavorable histology, you will be happy to start with chemotherapy. Okay, unfavorable histology.
I think the only thing for biopsy here that it's feasible and doable, you have to be careful of the pleural.
Yes.
Exactly.
Yes, the plural. Okay.
Like.
Okay. So tomorrow,
Exactly.
bone marrow evaluation plus biopsy.
Biopsy. We do still biopsy this patient?
Yes, for this patient, if you are happy to do that.
Because I heard you want to remove a tumor.
No.
It could be.
Or we can do biopsy.
But-
Both are correct.
Yes, because we said this morning, it's nice before operation to know what the story is.
Yeah.
So we want to know what the story is. You know, if, for example, you perform a surgery and you do the same at the same time bone marrow evaluation, and you have the results showing that the bone marrow is invaded, because despite the absence of clinical signs, the bone marrow can be invaded. This is a 4 years old girl. 4 years with a large tumor like this can be a stage 4. Stage M. So we can move to the next one.
Yes.
Can you...
Ca tiếp đi.
Cái này vẫn
Tóm lại vẫn là
vẫn là
đánh giá
cái xương.
Quan trọng là cái tủy xương mà âm tính thì
Tủy xương.
Chứ nhưng mà
không có cái đấy.
bác ai có chưa?
đang đi hỏi.
Tức là ông này sẽ là standby, đúng không? Chứ cũng chưa chắc. Cái này chưa cần vội.
Chưa cần vội. Cứ bình tĩnh, đây là cái gan này không cần quá vội vã.
Khác nữa.
Tiếp lên.
Now I will present the question. The patient.
Con này phim là cái link lúc nãy cơ, link. Chị phải thoát ra làm chị bật lại link cho em. Cái Zalo của em đem nhỉ? Như thế Zalo của em.
Cái nào đang mở ấy, lúc nãy mở.
Mày mở ra
Có phải cái lúc nãy mở không? Cái kia nó ở dưới lúc nãy. Xem ở đâu đó. Đây.
She has a short abdomen, no hepatitis, and blood pressure is normal. Investigation at the diagnosis, LDS level and amylase and lipase are normal. Abdomen CT, so that's the pages for solid history tumor. Ultrasound irregular hypotenuse mass about 8 centimeter for the digits below the left kidney. Where diagnosis follow-up several plate injuries. Hence we would want a little 5C for the patient. No. Right.
Có công tướng.
No, yes. So tell us first the location. The location, is it really in the tail of the pancreas?
Yeah.
Yes. So it's France.
Yeah.
Hi, France.
As you said, it's the diagnosis most probably is solid pseudopapillary tumor or France tumor, and in this case, we do
Yeah.
imaging alone.
Here's a CT.
Just CT.
Yeah.
With the MRI,
We can see better the pancreas and what's left of the pancreas for the surgeon to know how much of the pancreas he can leave and he can remove. MRI to see better pancreas for the surgeon.
and also for the tumor to identify the tumor, because we have
a solid capsule, fibrotic capsule that is really characteristic also of France.
So it's nice to have.
And you don't want to make what we call a rehearsal with the ultrasonography and the surgeon. You don't like that anymore. I remember the name of the story is the rehearsal. You go, the surgeon goes to the radiology department with the patient and with the radiologist, and they do the rehearsal of the surgery. You don't do that anymore.
We are not in the same hospital.
You know, I know,
No, I know
but
you don't do that.
tu vois ce que je veux dire? You see what I mean? La répétition avant la chirurgie avec une pratique. No, you don't do that. Never do that. No rehearsal, just MRI.
We talk a lot.
Yeah.
Bây giờ sẽ chụp mổ từ.
Yeah. Okay. So good.
Anh chị bảo sẽ mổ luôn.
No biopsy. Never.
Why?
Why? Ah.
Okay.
Yeah. Explain.
Yeah, it's close.
Nghe.
You need to explain why. Why you never biopsy this type of tumors?
Those type of tumor there are a lot of cystic components, and it's really fragile. Okay, it has this capsule, but it's really fragile. And when we put the needle, and it's in the peritoneum, so we can put cell in the peritoneal cavity, and it's a totally another story. There are cells in the peritoneal cavity. So when it's characteristic of friends and they are cystic like that and everything, you do not biopsy. So not make worse prognosis by putting cells in the peritoneum.
And because it's difficult to make a posterior approach for the biopsy. Posterior approach through the kidney.
Thì tại vì nó rõ bản chất như tôi hỏi. Tại vì là chưa rõ là nó là tụy hay không. Còn chưa rõ là tụy hay không. Nhưng mà cái này chưa rõ là tụy hay không.
Yes. And his artery.
Cái này trông kỳ quái, nó không rõ là tụy lắm.
Đây cái mô tụy.
MRI at 6 o'clock.
The small part of the tail of the pancreas.
Yes.
Yeah.
In
front of the mass.
Yeah. You're right.
Will go.
Này là mổ.
Mổ arise from the pancreas tail.
Yes.
You have a stacker?
We need to take a MRI.
I think not.
It's better for the surgery.
But in this case, we need take a MRI or not?
Ça suffit le scan pour le tour.
If you can,
it's better. But Pascal
because you
said
can see the MRI for France. If you,
it's okay. We can if it's.
No, the question is scanner is enough for surgery?
Sure.
Yeah.
Okay.
Yeah.
Okay.
So does it mean that you will operate this patient tomorrow?
We can. Okay.
Ôi khỏi cái đầu đi.
After the other one?
Après les normes neuro.
Non, celui-là, il faut pas le voir.
Hay là mình đã loại được một
Hai cái. Như các cái lan của tụy là
loại được một thằng.
Tại vì hôm trước đọc là mọi người bảo là chưa rõ là tụy.
Chưa rõ cái mà. Thế thì trong những trường hợp như thế đã nghi ngờ cái u đặc giả nhú đi chụp MRI.
This surgery?
Yes.
Sorry, it's okay.
Tomorrow?
Depend on choose I think is one case.
Thay bệnh nhân đi.
On Friday?
Friday kiểu em mổ được cả thứ bảy với thứ sáu với bà nữa không? Bạn muốn mổ 2 ca?
2 ca, tôi làm ngày mai đi thì
Cái nằm lâu chị Lan ạ.
Gì?
Và lâu lắm.
Cái này đang nằm ở chỗ nhà em. Chọn ca này nhá, không mổ thận nữa nhá.
Cái kia nó hơi.
Yeah, maybe you
come next week.
You prefer this pseudo pancreas neuroblastoma?
No. Ask the surgeon what he prefer.
Em check chọn ca nào?
tùy bạn.
It's up to you.
It's up to you.
It's anglais.
Which do you prefer?
It's up to Madame Pascal.
You guess you can choose.
Neuroblastoma.
Cái ca kia.
The most difficult case, but with a CT scan tomorrow morning. And if you don't have the CT scan tomorrow morning, we do this case.
Okay.
Yeah.
Tức là bây giờ bà thích chọn cái ca neuro mà số đầu tiên.
Nó khó hơn. Và ngày mai mà có phim thì sẽ mổ.
Kịp đâu.
Em
Chị không kịp, em sợ không được.
Không kịp được thì thôi. Yên tâm, em sẽ chụp được. Từng này người làm sao không chụp được.
Liên hệ luôn.
7 giờ cái là chụp luôn.
P nó có từ 7 giờ.
Cái mail là từ mấy giờ?
8 giờ.
Thì 8 giờ chụp xong phát thì đến 10 rưỡi thì mà làm mà không xếp
Can we
được.
go to 10 giờ mà làm thì đến chiều và em đi thì
Không, nhưng mà 10 rưỡi người ta mới làm được, không có bài, có bài giảng. Không làm được giờ này. Nhưng mà bà không mổ được trước 10 giờ, bà còn phải có bài giảng.
Cho bà giảng sau đi.
10 giờ trở ra bà mới mổ được.
thế em làm cái nó hết chủ. Cho bạn.
Được rồi, ok.
Hai ca đấy hoặc này thì
Candidate của biopsy có không?
Con đây.
Con. Tiếp.
Lắm đây.
Nhanh.
Đọc đi.
Nhiều lắm. Thế bạn nhiều lắm.
Can you look at the next one?
Yeah.
Nhẹp.
Stop xe này.
Đây.
Đây. And he's 28 months old, a diagnosis, and he was admitted with fever and abdominal pain and ultrasound at the local hospital still takes a retroperitoneal tumor. And the clinical examination, he was nurse and he had no abdominal pain. His blood pressure is normal. On the abdominal CT, we found a mass in the left
Thì bây giờ chị xe cái người thôi xe cái này chỉ một trong hai đó thôi. Anh hiểu không? Không được
vessel
xe được.
measuring about 12 cm and the mass. So he tells us enhancement with area of neurosis is invades the left renal vessel and aorta above the right renal vessel and invades the left dorsal muscle and compress the left renal pelvis and the left pelvic lymph node size about 8 mm. On the chest CT, we found lymph node located posterior to the aorta, measuring about 15 and 9 mm, and lymph node in the posterior lower pediatric, measuring about 1 cm. Lymph node at the left lower cervical region, measuring about 15 mm. And now she having infection status with a high white blood cell and CRP is elevated and bone marrow is expanding and FBI and BMA is expanding and he was diagnosed with suspected neuroblastoma, stay L2 with LTS or negative, and we'll discuss about the needle biopsy for him.
Bỏ cái I have an idea. But I let you.
Hoại tử à? Cái này điều trị rồi chị?
Chưa được mới đâu chị.
Later.
Chị nghe cái này.
Up to you.
Chị nghe cái này.
That's one thing, but there are other things that I know. Yes. Second point. IDRF, necrotic, ILD. And lymph nodes everywhere.
Yeah. Everywhere.
And can you? Yes, we were told that there were lymph nodes in the thoracic area and in the cervical area. Do you confirm, or is it such?
No, this thoracic. Nhưng đây vẫn là bụng ngực lên ngực như thế nào?
Okay.
Đây vẫn là thụ hoành mà, đã lên ngực đâu?
28 pounds. Yes. There are two possibilities. Three possibilities. So, what do you think? Are you planning a corneal biopsy tomorrow? Okay, good. I think you agree. We can agree.
Yeah, we can agree with that.
Yeah, okay. But you don't think that you can easily have the lymph node in the cervical area, which could be easier to take? You are not happy with that.
Cái này vẫn là dưới mà chị.
You are not happy. It's super. Yeah. Yes, it's danger of pneumothorax.
Yeah. No, it's not only the danger of pneumothorax. It's really near the with ultrasound, we do not very well
you don't see very well.
Understand.
Yes, okay.
So this one is not just one. This one is small, and the mass is really big. And I think it's easy to do. And I think there are a lot of tissue, I don't know if they are going to be tissue or not, component if we take like the capsule of the neuroblastoma.
So the first hypothesis is neuroblastoma mechanismplified. The second hypothesis is neuroblastoma with segmental abnormalities. And I have a third hypothesis, but you will say I'm wrong, which is rhabdoid tumor. Because you can have a rhabdoid tumor like this.
It's more
Yes, but, yes.
Here it's really big problem.
Yes, sure. You can have a rhabdoid tumor in this area as well. Okay. Never. Yeah, I think you're right. This is the. Yeah, sure.
It's more neuroblastoma.
Yes.
In rhabdoid, we are studying. It's more like a neurogenic target development.
Okay.
So the aspect is a lot more in favor of
Yes. Okay.
Maybe would be able to perform up.
No, I don't think so because it was really so rare. So you have tomorrow. You have the pain of doing that.
Yeah.
The pain of doing that.
This biopsy for tomorrow.
Yep.
Yeah.
Okay. And the bone marrow is evaluation as well.
Yeah. What about the lymph node? Because we have many.
We don't need it.
It's there. They look abnormal.
Yeah.
They look abnormal.
Yes. Not only by the size, but also by the
size. They are round. There is no fatty healer. The central of the node is not fatty. It's round. It's heterogeneous necrotic as the same as the primary tumor. So it is metastatic.
So even if you have no disease in the bone marrow, this is what we call a stage M, because we have the disease elsewhere. You don't have to document.
Can we see the
Usually, when we use MIBG scintigraphy, these things are lighting up. So we are accustomed not to make any evaluation. Maybe we are wrong, but these nodes are going to be positive in MIBG, but you don't have MIBG, you don't have PETs.
Không cần sinh thiết hạch nữa.
Vì người ta thấy nó không, ta mà di căn. Hạch là di căn rồi, nếu mà hạch tức là cái hạch mà bất thường, nhìn cái hạch ở trong nó bất thường. Nên là cho
which approach do you prefer? Yeah, but paravertebral or
yeah, I think under the kidney, if you go down under the kidney, yeah, here is the kidney,
but this place is too much necrosis.
Không cần sinh thiết nữa.
Yeah, you're right.
Yeah.
But you have no necrosis, you have tumor between the kidney and the spine.
Here, we are too close to the peritoneum. If we go here, we don't know very good if there is some peritoneal that come here and go here. So the best, if you go there, and we take here, everything that is tisular here, and then we can take a little bit of the fatty, normal fatty with the capsule, then we know that we are good. And if she will have operation or anything,
why don't you use
we will take out the kidney. So the best here, you see, there is also here. We can go here is the best.
What I like much is to inject.
But it's a small trial.
50 of serum.
No, is it? No, it's not long way. 4 centimeter and a half, like it's a small needle.
Có thể là SCA toàn là có 6.
And you don't like to inject physiologic serum?
We don't need.
Like Hervé does sometimes?
We do it when we have structure we want to take away.
Okay.
But here it's easy.
Yeah, you don't need.
No.
Okay.
You see there are a lot of tisular area around next to the aorta, under the.
Okay.
And I think if you put it's right side,
họ đi vào đây thì họ sợ có cái phúc mạc này. Đấy, mình sợ là đi có phúc mạc lên một chút thì nó sẽ có thể tế bào.
Excuse me, I would like to ask you about when you have to perform open biopsy lymph node.
Oh, in neuroblastoma, we rarely perform open biopsy lymph node.
Đúng rồi.
we need some time for rhabdos. We need to do biopsy of the, if we use the sentinel lymph node evaluation to pick the ganglions, which are the first three lymph node. But this is for rhabdo, because for neuroblastoma, we really rely on MIBG, which shows us. But if we do not have MIBG, the radiologist can tell us how they see the lymph node and what they think about the lymph node. And in this disease, when it says like this, we really are very, we think that the CT is very much informative. So we don't need to take it, because, you know, this is, although this is a very important conclusion to say, yes, we believe the radiologist. We don't need the addition of the pathologist, except in some instances when there is a doubt, you will tell us as a radiologist there is a doubt, and then we take the final aspirates. We don't make open biopsy of lymph node like this in neuroblastoma.
The cervical one is big, so I don't think we find even aspiration in this case for the cervical one. You don't need.
You don't need. Okay.
Tức là cái
thì chỉ chọc cái phần là mình toàn open mình bốc
PET scan.
tức là cái
the PET scan is, Pascal is right in the sense that if you do not have MIBG, you could replace MIBG by PET scan, and you will do it someday, because I think you need to have something to replace MIBG. So the situation right now in Vietnam and in other countries where you have a PET scan which is available for money, and where you have no MIBG, is so that you will have someday to gain information in using PET scan at diagnosis and after treatment. Because, you know, when I work with the GNN, with the Global Neuroblastoma Network, and when we try to discuss the cases, we are discussing cases on the basis of PET scan, which has been done after induction, but with no PET scan at diagnosis, and we are talking about PET scan results like we were talking about MIBG results. And I think it's nonsense, because we need to have more information about this disease with PET scan evaluation. And if you look at the literature, there is very, very scarce literature about PET scan. I regularly look at that, and it is always the same story of 5 cases evaluated by PET scan and as well as the MIBG. I haven't seen a series, because, you know, if you want to do a series of cases, you will have to expose the children to MIBG iodine 123 plus FDG PET scan. So it's costly, and it's maybe not ethical, ethically approval. So you need to make, in the situation where you are with no MIBG, I think you will need to make it sooner or later.
Tóm lại là chúng tôi cũng muốn hỏi các bác chuyên gia về cái vụ hạch ấy, thì là những cái hạch mà chúng ta có cần sinh thiết mở hay không, thì bác ấy nói là ví dụ rhabdomyosarcoma thì bắt buộc sẽ phải sinh thiết. Thế còn với u nguyên bào thần kinh thì các bác ấy có cái MIBG rồi thì các bác cũng không cần thiết phải sinh thiết. Nhưng mà với điều kiện Việt Nam mình không có MIBG thì với những cái hạch mà nó rất là kiểu như là điển hình của cái hoại tử rồi là tổn thương mà các bạn chẩn đoán hình ảnh nghĩ là đấy là cái hạch di căn, thì cũng không cần phải làm sinh thiết. Cái đấy phải tin các bác sĩ chẩn đoán hình ảnh. Đấy, còn nếu mà chúng ta vẫn chưa biết là có rõ hay không thì chúng ta còn có một cái công cụ nữa là cái PET-CT để mà chúng ta chụp. Thế nhưng mà thực tế ở các nước đang phát triển thì PET-CT thường không thể chụp ngay được, mà chúng ta lại có thể khi là phải chụp sau đấy. Thế nên là cái ý nghĩa của nó cũng không được là nhiều lắm, bởi vì là nó đã sau điều trị rồi. Thì cái việc đấy mà so sánh thì nó cũng rất là khó để mà biết rằng là cái tổn thương hạch ấy là như thế nào. Thì tóm lại là có thể là với trường hợp mà mình còn nghi ngờ thì mình chỉ cần chọc hút thôi, chứ còn cũng không cần thiết phải sinh thiết hạch. Có bằng chứng tế bào ác tính là mình có thể nghĩ chẩn đoán đấy là bởi vì mình đã có sinh thiết rồi thì nên là chỉ cần biết là cái hạch đấy có tế bào ác tính. Có dịch gì sao nữa?
Không, nhưng mà ví dụ nếu không sinh thiết được hạch thì chọc hút, còn nếu không chọc hút thì không sờ thấy thì không chọc hút được ấy. Thì coi như dựa vào chẩn đoán hình ảnh.
Dựa vào chẩn đoán hình ảnh, tức là chẩn đoán hình ảnh phải tin người ta. Phải tin người ta.
Trước giờ mình là hay open
biopsy cái hạch đấy, nhưng bây giờ không cần thiết.
Chỉ sinh thiết 2 cm thôi.
Mất việc rồi. Okay, next case. This case is tomorrow corneal biopsy.
Chị đâu có stop xe đấy, giờ stop xe đâu?
Để cho nó
nãy giờ stop xe à?
A female and a diagnostic and we have
phải stop xe luôn.
clinical examination her blood pressure is normal. On the abdominal CT, we found a mass at the left contain more concentration, and the mass size about 5 centimeters and no entry of vessel or infection of the spinal cord. They are EAF negative and several nodes with concentration as seen along the para-aortic region. Also level of the kidney with the largest area about 13 the chastity is normal and the on-arrow oscillus is now expanding she would diagnose with suspected neuroblast.
Em cứ để bên đấy dẫn chỉ khi nào nhảy lên để nhưng mà mình suy nghĩ lên chẳng cũng có động gì cái đấy đâu. Lúc nào để em sờ vào thức mã em ơi, mã chưa 250 921
Nước cái này đi. Nước cái này là sinh thiết nữa.
Do you think that the pain is related to the mouth, or is it a surprise? Because sometimes you have pain and you find something, but the pain is not related to.
Often you find that it's not related.
Yeah, especially in L1.
thường thuận lên đây vị trí tự thận ngủ được
không đẹp như này mà
Dạ lạnh rõ đấy.
này
Thịt nhá.
chụp tiêm đi.
Nếu mà cái gì cần
thì nó ở đâu thì nó cái thượng thuận ở đây rồi.
này là 5 phút
Anh lâu thế nhưng 5 phút.
1-2 giờ này. Mình xem cái trước tiên là cái 5
Thì em thảo luận bà đi. Nói với chị. Em nói đi.
mà thôi ngày mai bố trí một tỷ
Không, mà bà muốn mổ cái
What do you tell us?
euro mà.
và thế thì
Sao 11, 12 giờ 10 rưỡi.
cái khối này thì không có vôi nhưng mà cái hạch có vôi.
You see calcification.
đang giờ ra hết.
Inside the mass we see no calcification inside mass. Yeah, but some lymph nodes with calcification. But the surenal,
Can you put this?
the adrenal gland is quite normal.
Can you put it in 3 plane?
Three plane, một cái.
It's one of them.
So lymph node calcification.
Không cần thiết sinh thiết kỹ. Không cần sinh thiết.
We can stay another week.
Hạch hoại tử. Hạch hoại tử.
Adrenal gland.
Hạch nó mất mỡ. Số chút. Mất mỡ số chút gì.
It's a ganglioneuroma. or at least an intermix can be anomalous.
You see, at some spaces we go to the coronal space, but I think we should be in the
Anterior.
anterior. There's a posterior.
Post.
Ah, I think there is a.
You think there is a nodule?
Maybe Neil.
D'ailleurs, si vous laissez le bras.
Faut laisser le bras.
We think that maybe here. Calme-toi ici.
Anh gọi Trân cầm đi.
Oui, ben j'essaye, attends.
Anh gọi Trân cầm.
Here, ici. Here. The anterior arm. It's really exophytic. We can see a lot of the normal, but I think the anterior arm is a little bit amputated, and the mass is coming from the anterior arm. Yeah. So maybe Pascal, that really wants to be in the OR, could have done a partial adrenalectomy. You see that here, if it's not really normal.
You don't see a nodule in the mass. You don't see something which is heterogeneous at what level?
Why homogeneous?
Yes.
It's so homogeneous.
Yes.
Yeah.
Ouais, si. Ouais, mais je trouve que c'est pas assez hypodense. No, I don't think. I think it's gonna be, there would be some kind of neuroblastoma in it. It's a little bit,
It is from a neuroblastoma.
it's not very hypodense, like, I don't know, you will see, but I'm not sure it's a ganglioneuroma. I think there is some kind of blastoma in it.
Yeah, because some lymph node calcification.
Yeah, also. Sometime in very mature ganglioneuroma in older child, you can find some calcifications. But you see, I think it's not enough hypodense and maybe a little bit heterogeneous. But either way, it's not pathologist.
Wait and see.
Zach is here.
You can.
No, we do.
We can play and we can play and guess.
Và câu này là thôi, không phải là biopsy nữa nhá.
Mổ luôn nhá.
Không có ý đây rồi em.
Can sổ tin nhỉ?
Không, chỉ có hạch ở cạnh phúc mạc, sau phúc mạc tí thôi hả?
Yes, you understand.
So partial adrenalectomy. You keep
the posterior arm.
The medial arm.
Yeah. Cái cắt bán phần cái
Cứ bảo tồn con cái
thấy chưa?
Còn ca nào sinh thiết
You
không?
agree? You agree for surgery, for primary surgery? Yes. Do you agree?
It's a female under vomiting, abdominal ulcer, incidentally will very medical history. On examination, she soft abdomen, no hepatosity, no rest, respiratory. In investigations and diagnosis, is higher urine catecholamine is heavy. Abdomen CT shows the urine very fast. Bring about 3 centimeters. The lesson shows assessment after contrast. Cystity normal, brain and normal. It's very long, normal. And secondary diagnosis, bilateral value, mass should be from little mass or surgery for patients.
Chị có rồi, chị ngồi đấy rồi.
Parce que c'est
24043 24043
une fille.
24043
Elle vomissait.
4533
À quoi?
4533
C'est très jeune.
Non, mais j'ai un neuroblastome, ça fait bien de doigts.
Yes, but this one is. C'est pas inframédicinal, ça?
C'est le corps de
Au-dessus.
sur le corps. C'est très haut. C'est très haut. Sur le corps.
Do you see IDRF?
No. Yeah. It's contact. Yeah.
Close
Close.
bao quanh
Close thôi. Không phải
Do you feel to go?
tiếp xúc. Yeah. Contact with the right renal artery.
Yeah. Yes, but do you? Yes, c'est jeune. I got the neuron. Ouais.
Je pense qu'on ne saura pas de son There is nothing elsewhere, nothing in the lung, nothing in the liver, nothing in
It was written, nothing elsewhere.
and the ovaries.
Your ovaries. Why?
Sao 2024 nó chụp cái gì? Chắc là không phải liên quan đến triệu chứng của não.
Ouais. Non, c'est pas typique, hein.
Nó bị viêm màng não ngày xưa, bây giờ là tình cờ phát hiện ra.
Mắc cơ có gì không?
But do you think this is an emergency? I think it's not an emergency.
No.
There were some vomiting, but the vomiting can be related to something else. The blood pressure is normal.
Yeah.
You want a biopsy for that?
But
it's small.
Yes,
It's small. It's too bad to make a biopsy for such a small lump.
Non, mais on cite
Something. Make something in it. Put something in it. I would watch. I would watch.
Mais on ne surveillerait pas sans avoir fait une IBG, sans avoir fait.
Yes,
Et là, ils ont pas.
Yes.
On surveille quoi? On n'a pas la même. Oui, nous, ils n'ont pas.
Yes. So since we do not have MIBG, we are more prone to propose biopsy or
Fine needle aspirate.
Fine needle aspirate, not something very aggressive.
But it's not
fine needle aspirate because it's not a large tumor. And yes, obviously VMA and HVA, but it might be negative. I would propose you need HVA, but you don't do dopamine, don't you? Dopamine. No? HVA, VMA, dopamine.
Dopamine hình như không làm cái nào.
I think paravertebral, but it's not foraminal.
We have
paracostal.
Yeah.
Yeah, the clinical examination. The clinical examination is otherwise normal.
The only thing is
normal.
No.
But we did.
Because it might be something that is quite old.
Even like that.
So
whether we can perform fine needle aspiration, if the pathologist can read some
in our hands,
like cytology,
we perform MIBG
and he can give an ID. If it's a neuroblastoma, he can say it's a neuroblastoma on cytology.
We don't know what is the status. Is it bigger after, before?
The thing is, we have this anesthesia.
So we would probably not do
breath when we want it.
A biopsy, but I think in this situation, you do not
full expiratory, then we block. Like that,
so I think it's nice to have
during the procedure, or when he's full in expiratory mode, because the pleural sac will be higher, and you can go just over the renal kidney. You go like that, like that, like that, like that.
And do you think we should inject some serum?
Yeah. I think you put like a very fine needle, a very small needle, and you put serum.
Yeah.
here, and then you go. It's not easy. It's really not easy. But like you see, if it's in full inspiratory mode, not expiratory, for lowering everything and for closing the pleura, we can pass by him. And because he's 1 year old, we see really well under ultrasound. So it's feasible. It's hard, but it's feasible. At least try needle aspiration. If biopsy will say we do not have enough to go to open the biopsy, at least find needle is feasible.
Tuổi nó lớn.
It depends on the situation. After aspiration, maybe we do.
Yeah, if it aspiration go well and real, we can perform biopsy in the same.
And tomorrow we by the pathologist.
Oh, we do not have to have the pathologist in the room.
The father.
We can send him the cytology and everything.
Albini.
But I think it's not easy. Yeah. It's kind of a difficult case, but we can. One time.
Oh, 3 children.
I think we shouldn't do that. One time we did it transhepatic through the liver. One time we did that because really there are no way and we couldn't and the surgeon didn't want to operate and we had to do something. But I do not recommend passing through.
Là cô ấy nói là cái u này nó ở vị trí nó khá là khó sinh thiết vì thứ nhất là kích thước của nó nhỏ, thứ hai nằm sâu. Thì ở vị trí này thì nó có cái khoang màng phổi và đứa trẻ một tuổi
10 tuổi
thì nó thở rất là nhanh.
Một
tuổi thì nó thở rất là nhanh. Vì thế ngày mai thì cô sẽ chọn là chọc hút kim nhỏ trước. Thế thì cái lượng tế bào lấy ra thì nó cũng đủ để bác sĩ giải phẫu bệnh người ta đọc kết quả.
Hút kim nhỏ, chọc hút kim nhỏ, final.
Và có thể cô sẽ chọn cái đường mà nó sẽ đi xuyên qua đây. Đấy, xong bơm một chút nước muối vào đây để mình tách cái thận nó rộng cái đường tiếp cận ra, xong rồi mình sẽ chọc hút. Vì cô nói là cái kích thước này nó bé lắm, nó khoảng 2 cm thì nó cũng không đủ để cái gọi là cái máng co vào đến nơi.
Nhưng ông đi sông thì ông đang không muốn sinh thiết được, mình theo dõi đấy.
Vâng, thế thì theo dõi đi.
Đến đi cô trình diễn mà. Cô trình diễn mà.
Cô không có. Thực ra cái này nhà mình sinh thiết được kia mà, mình vẫn bơm nước
vào mà, vẫn ông vẫn làm mà. Thì không cần phải trình diễn nữa. Không phải trình diễn.
Ngày mai cho cô trình diễn mà.
Thế là đi một ca trình.
Mai 2 ca
thì mới có một ca. Ca này thì làm đi. Ca này
ca kia là ca 1, ca này ca 2. Ca kia cũng không hề dễ nhé. Ca kia nó rất nhiều hoại tử. Đấy, lấy được cái kia cũng khó, lấy đúng cái phần thịt của nó. Các khối u to chứ chắc là dễ, bởi vì nó hoại tử nhiều lắm.
So conclude the biopsy
at the same time as bone marrow evaluation.
Because lúc nào phải có bằng chứng.
Tức là ngày mai thì sẽ làm sinh thiết bằng kim nhỏ cộng với cả làm tủy đồ, sinh thiết tủy xương.
Đó là kết hợp luôn gì?
Kết hợp được tủy.
Next week. Next week, no emergency.
Lần mai không phải làm cấp đâu mà làm tuần sau.
Là cho cô làm.
You want to go together?
Đây là
I have to spend all day with you to talk.
With pleasure.
After the lecture.
The patient is born
tomorrow afternoon.
It's already done?
Aspiration, not biopsy.
Oh, you do aspiration before doing.
Yeah, because we have to take the generation anesthesia is very critical.
Okay, so yes.
Bone marrow aspiration.
But you will do general anesthesia for the fine needle aspirate.
Yes.
Okay. So I just want to stress one point. You do not need to make bone marrow biopsy in a child with 1 year old. Under the age of 18 months, I think it's very difficult to do a good biopsy. And I really like to stress that this is bone marrow aspirate is sufficient at this age. Although it's written everywhere that you have to make a biopsy, but I've never seen a nice biopsy made in an infant. Because it's always you bring cartilage or things like that. You have no biopsy really of the bone marrow.
Có làm bone marrow
So
không?
bone marrow aspirate is negative, so you do the fiber aspirate, and it's okay.
Chỉ chọc thủy thôi.
You could do it tomorrow.
Chọc thủy chọc
Okay,
không
now
có
we have
chọc
another surgeon coming in.
thôi.
Who wants to
Xong
operate the
thôi thì
patient
chỉ biết
tomorrow.
thôi.
And he's very
Ngày mai chỉ có chọc
Pascal.
thuốc.
So
Rồi.
you have a case to present? No.
Tiếp đi em.
So case number 7.
Yeah.
Next case is a female.
Một sáu không.
Chọc thuốc kim nhỏ.
Đấy, chút thế.
Hết sinh thiết chưa?
Hết sinh thiết chưa em?
10
Hết
years.
ca sinh thiết chưa?
Hết rồi à?
Yeah. No candidate. More. For biopsy.
Another candidate?
No.
Thôi đi về.
No candidate for biopsy. Only tomorrow we have two. One by candidate biopsy. Three, no?
Chị mở cái khác.
Only two.
Đăng nhập của chị nhá.
Blastoma.
Yeah.
The pancreatic, no.
No.
The second neuroblastoma.
Pancreatic.
There is two neuroblastoma.
Có hai căn neuroblastoma ngày mai sinh thiết à?
No. Two mà.
À, two.
One big mass with necrotic lesion. Yeah. And this one.
And the first one, no.
Cái ca thứ hai là mổ luôn hay là sinh
The
thiết?
first one is a surgery. The first
One là cái Trần Minh Anh. Cái phối.
Trần Minh Anh có
Tức là 3 ca cơ. Chị không muốn làm luôn.
after the scan.
No.
Trần Minh Anh có sinh thiết kim không?
Trần Minh Anh thì có đây, ông bảo có đây.
Có that is in the adrenal.
Hai bác sĩ
Một cái khối nhỏ này, mấy khối to đùng đấy.
còn một cái khối to nữa mà bảo là mổ hay không ấy.
Yes, this one, not tomorrow.
Cái mổ hay không là chờ mai chụp CT. Cái khối to bên phải còn là ADA âm tính.
Chụp CT xong để mổ chứ có phải sinh thiết ở đâu.
Cái khối to mà ADA âm tính thì chốt là mổ rồi.
Còn một đứa nữa lúc ngay đầu tiên ấy.
Đầu tiên là cũng phải chờ mai chụp CT.
Đấy không phải thằng sau đấy
Để thằng khối bên phải nó bảo anh tính để cho mổ không chứ.
Từ nãy giờ mấy
Cái là Trần Minh Anh là một
chị biết là gì?
Number 2.
Chị không thấy bước này nhớ đâu.
4 years.
Trần
4
Minh Anh là
years old. Suspected.
là hai sinh thiết kim một phút.
The case is a
Second case.
biopsy.
Yes, in order to know
Này là
also-
we have 3 cases.
and the-
2 biopsy and 1 FNA. Yeah.
Yeah, it asked me tomorrow.
Let's prepare perform biopsy.
Yeah.
We perform FNA and we'll see.
The last one? Yeah.
We'll see.
Okay.
Tóm lại mai có 3 ca, 2 ca sinh thiết kim, 1 ca chọc.
Nó gọi là cái ca chọc thuốc kia, nếu làm được sinh thiết thì làm sinh thiết. Bởi vì có liên quan đến di truyền đúng không? Làm sinh thiết tốt hơn.
Okay,
Thôi em đi về đây.
2025,
Thank you, em.
third day of November, yesterday.
Mai vẫn là làm chiều đúng không?
Thì đúng rồi, vẫn bình thường. Sáng vẫn là bình thường.
Abdominal distension. That's something about. Nói ra với bài khó quá. Có đấy.
Tiền không mà.
It's a ovary.
And it's the right one.
She's 10 years old.
Thì đứa nào của mình máy về mai
Phê chưa số.
đây là bệnh nhân.
Chưa trình bày bạn, chưa trình bày cái này. Đang trình bày.
Next.
The patient is a female.
Yes, we listen to you.
Can just she is in with increasing abdominal distension. Medical story is normal. Examination diagnosis. She has abdominal distension. No hepatitis B. Blood pressure is normal. Abdomen CT so hearing structure measuring about 18 centimeters with a thin wall and a very close contact assessment. It is expected to be the right ovary. Chest ethnicity is normal. LDS and acid. LDS level is normal. She was diagnosed specific ovarian cancer therapy with surgery for patient.
Hey, one thing is missing. The results of a biological evaluation of AFP
and beta HCC.
VCC. Alpha P beta CG bao nhiêu?
Ouais, sur le matin et le soir, c'est pas une chose. Hein. Le patient est arrivé en temps.
And AFP is normal.
Ah, AFP is normal and beta HCG.
Normal.
And inhibin B,
It's 1 week.
it's 1 week.
Yes.
Okay.
Both the base mass in the abdominal.
Yes.
Yes, the component of cystic mass, most of, and small parts, density and teeth. Yeah. This displaces the uterus to the right side. To the right side uterus. So teratoma is the diagnosis.
Yes.
Maybe due to the left ovary.
I don't know if it's the left because you see if you go a little bit up again. Okay. If you see the structure that is the vascular structure on the right of the cyst.
Right.
Yeah, this on the right of the cyst. The vascular. Yeah, this one.
Yes.
I think maybe Neela stay here.
Yeah. Go up.
Maybe.
This one. I think it's the ovarian pedicle. So when it's dilated, it can help you to say if it's right or left ovary. And if it's on the right, so most probably
Most
the right.
On the right.
Yes, even if the uterus is displayed on the right, it doesn't mean that it is left.
Yeah. Yes, it's always the same story.
Bà những cái tổn thương này
You have the impression it's from the left.
ở bên phải.
Because here, I agree with you that here it's the
Uterus here,
uterus.
yeah.
Okay. But then after the uterus, you have the fallopian tube and you have the vascular pedicle. You see here, it cannot be the uterus, it's too high.
Yes.
So here that you see, it's the vascular pedicle of the left, of the right ovary. And do not see the left because the left is normal. So it can tell you that this mass is most probably coming from the right ovary.
The right ovary.
Yeah.
Because the artery, the pedicle of artery from the right side.
Yeah, it's bigger. It's
Bigger.
Yeah.
Bigger than.
So most probably the pedicle is big because it's nourishing the lesion.
Nourishing.
So even if the uterus is displaced like that, can be the right ovary placed.
Can you see the left ovary? Can you see the left?
At this age, we will not be able to see. Yeah. Maybe in ultrasound, and it's not sure that we can see. But you see, we do not see the left pedicle.
Yeah.
So that's why I think it's right.
It's very interesting.
It's a trick that we have. Okay, even though there is no lymph nodes, and I think there is nothing in the chest. Because when we see, I agree with you that most probably it is a teratoma.
I'm not here.
But because you cannot say if it's mature, immature, you are not pathologist, we don't know what is the exact component of the cyst. We prefer if we say it's a germ cell tumor with teratomatous component, because we see fat, but we don't know if in the cystic component there is some immature component. We don't know. So we say it's germ cell tumor.
Yes.
With teratomatous component. And you have to compare it with the tumor marker. All is okay. You say maybe teratoma.
Cái khối này mình có thể chẩn đoán là một cái u tế bào mầm, có thành phần của mỡ ở bên trong. Và cái này mình nghĩ đến cái tổn thương khối nó có nguồn gốc từ cái buồng trứng bên phải, buồng trứng bên trái. Tại vì nó có cái động mạch ở buồng trứng bên phải nó giãn hơn. Bên trái mình không nhìn thấy rõ, nhưng mà cái động mạch ở buồng trứng bên phải to hơn, cho nên là khả năng là u nguồn gốc từ bên phải.
Il n'y a pas beaucoup de charnure.
Non, mais c'est cắt thôi. Cắt thôi. Ngọt nha. Thank you.
Ouais, c'est qu'en fait, quand tu as le pédicule ovarien qui est dilaté d'un côté et pas de l'autre, c'est qu'en général, tu sais, c'est de quel ovaire il s'agit. Des fois, les ovaires, comme ils bougent, tu sais,
Cái này
mais
có
des fois,
bảo
ils
tồn
bougent
không?
devant l'utérus majeur, ça dépasse
Thì
les
bảo tồn. Khi nào thì bảo tồn? Nó chẳng còn gì.
Donc, c'est ce qu'il faut regarder, c'est la veine.
Em hỏi đi khi nào thì bảo tồn? Em hỏi đi khi nào thì bảo tồn?
Et des fois, c'est comme ça que je trouve l'ovaire. Hein. Oui, je suis plus.
Khi nào thì bảo tồn?
When should we research the ovarian tissue?
Yes, please.
But when?
When?
When? Every time. You try and you succeed. Because when it's a huge tumor, you take your magnificent glasses and you find the plan between ovary. So you have to cut the capsula and you find the plan and you go to dissect between the ovary. So you have an ovary. When it's bigger, you have an ovary, a streak, like a streak gonad. You have the ovary very planned. But when it's small tumor, you have nice ovary. So you have to try to keep it. Because you can have another teratoma in a few months on the other side. Could be.
Yes, I am with you.
Take a picture.
Oui, ben, je peux pas.
Serious picture, not looking at the. I was writing.
Mà lại chốt là cái này là
I was writing a note to you.
this can be into perform research tumor.
Okay.
Yeah. Next.
Save the ovary.
Yeah.
Okay. Case 8.
Yeah.
So you said we had 9 cases. We are almost at the end. No, 18.
Theo case.
Oh, 10. So we have case 8.
The 9 case is a male patient and he was 8 months diagnosis. He was admitted in 2025. Other diagnosis on abdominal CT, we found a mass in the left appendix measuring about 12 centimeters and showing pediatric enhancement after contrast administration with three suspected thrombus in the inferior vein fever and the left branch of the portal vein, and the chest CT was normal. The AFP level is very, very high, over 90,000. And other time we didn't because the tumors were so less. And he was diagnosed with hepatoblastoma protecta with the suspected thrombus in the inferior vein fever and the left branch of the vein, and who were treated according to self-pantry protocol with high risk.
Sorry, can you repeat the type of the histology?
Ils l'ont pas fait. Ils l'ont pas fait, ils ont pas biopsié parce que c'était trop gros.
To quá nên không xin thiết kim đúng không?
There was no biopsy?
No biopsy because at first the risk of biopsy is dangerous.
Okay.
The tumor is too big.
Too big.
Non.
I don't see. Cái khối này nó nằm
Non, je suis pas d'accord. Cái này điều trị mấy đợt rồi chị? Là je suis pas d'accord.
Điều trị mấy đợt rồi em?
Moi non plus.
Tức là nguy cao.
Pas que j'ai pas tout.
7 cycle. High risk.
Vị trí nó hơi khác so với vị thường.
The left lobe.
And
Left lobe. This is the first scan. Previous and now here. Previous one.
The tumor differs in size from 12 centimeter to 5 centimeter and still have thrombus in the left hepatic vein, but the AFP level decreased so much from
Reverse is bigger.
8,000. And
this is
after 6 course of chemotherapy,
the first
AFP level is
the first
4,000. but after 7 course of chemotherapy, the tumor doesn't change so much inside, and its size still about 5 centimeters and still has stronger
Okay.
and the AFP it can to increase from 4,000 to 7,000. So we will discuss about the surgery plan for this patient.
Yeah.
So can you
Can we go back
you
one?
yes make
First
the
one. Yes.
description?
Yes. The other one was the big tumor. Yeah.
No, don't forget that the treatment of hepatoblastoma is surgical treatment. Chemotherapy is an adjunct.
It is the first time of the scan.
Quite large.
Big mass involved. The left lobe, the middle.
Good.
Okay, which hepatic segment are the 2, the 3, is the 4 also?
4, yes.
Yes. Here, we see the thrombosis here, and in the back. Here. And more, it's bigger.
Yeah.
Okay, and here, okay, thrombosis. And all the, so we can see some that. So the left, suprahepatic vein, the inferior vena cava. The right is good, the middle is encased by the lesion. So first, pretext, what would you say?
3.
Because there is only posterior 6 and 7 who are.
Posterior segment.
Yeah, I agree.
Yeah. And associated with thrombosis.
Yes, so V plus or not? The left portal vein here is not thrombosed.
Yes.
But there are thrombosis.
The middle.
Yeah.
I think the middle also.
Yeah.
Thrombose. And in IVC.
Yeah. Okay.
This.
Yeah.
So it's still the right auricular. It's
right before.
Yeah.
It's the vena cava, but at the junction with the auricular.
Yeah.
So V plus.
And the left portal vein.
Yeah.
Smaller than normal.
Yeah. I think it's encased.
Encased.
Yeah, but encasement is not V plus. We have to have. Okay, so V plus because of the thrombosis. Extension, multifocality, yes or no? We're gonna say.
Yeah.
It's one big tumor, or is multiple tumor?
Only one.
Only one. Look M0. Is there any extrahepatic involvement?
Yes. Left and middle.
Yeah, not vascular, extrahepatic through the capsule, through the peritoneum.
This is a small voice. So
yes.
So I think it stick to the abdominal wall.
Yeah, okay, maybe. But we do not see the invasion of the muscles, so hard to say.
Extrahepatic.
Yeah. This is suspicious. Do we have like some fluid in the lower abdomen? No.
No.
Okay, so
Plus and what plus?
Je pense qu'il y a un petit hématome sous-capsulaire.
Okay.
There is a little fluid here, but I think it's still subcapsular, and we don't see like extravasation into the peritoneal cavity. So I think it's tricky. We can discuss E plus or not.
So what you call is E plus.
Extra hepatic involvement. Ils n'ont pas de biopsie.
Extra hepatic.
Yes, when you have pretext, V plus or not, P for the portal vein, yes or not. Here you are encasement but no thrombosis, so P0. M, we said it's unifocal, so M0. Ensuite, E, extra hepatic localization. We can discuss if yes or no because of that, but I think it's subcapsular, but we can discuss it. and there is still one N. Is there any nodes or not?
No.
Yeah, I agree with you. I think there is no node visible. So N0, mon prétexte. Puis,
Phân độ của pretexte 3.
Cái ca này em nói không hiểu phân độ của bà.
Phân độ của bà ấy thì cũng vẫn như thế thôi.
Không, nhưng mà tức là ý là trong cái ca này thì bà cũng nói
thì là pretexte 3, pretexte 3.
không, tức là cái mạch ven viết các thứ của bác cái gì
huyết khối tĩnh mạch gan trái lan lên tĩnh mạch chủ dưới là IVC. Thế còn cái hạch không có, cái thâm nhiễm ra ngoài gan thì cân nhắc xem là bây giờ mình sẽ phân tích xem là nó có hay không. Tại vì mình thấy có một ít dịch ở sát cái bao gan ở phía trước, tuy nhiên mình lại không thấy dịch ở phía dưới, thì đang theo ý kiến của bà ấy thì khả năng là không phải là nó lan ra bên ngoài, nó vẫn còn cái bao vòng tế bào. Nhưng mà cái đấy thì phải xem lại để đánh giá lại.
Bây giờ nếu những cái hạch mà ở rốn gan ấy, nhiều khi nó cứ lờ mờ ấy, thì phân biệt thế nào? Bởi vì có một số ca bọn chị cũng đã sẽ tìm ngày mai cái, nhưng mà nó có
những trường hợp mình không thấy trên MSCT, nhưng mà
tức là trên CT mình đã nghi ngờ có hạch ở rốn gan, thì những cái trường hợp như thế thì phân biệt như nào là có hạch không ạ? Bởi vì nó nhìn nó rất lờ mờ.
In some case we can see some small lymph nodes in the higher liver.
Yeah.
So how to evaluate?
It's hard to say, but usually in FIT protocol, and the reference have the last word if he's going to say yes or no. I think it's difficult, and if they are really big or you see too much lymph node, it's maybe better to say there is suspicious lymph node, and to discuss with the surgeon if at time of surgery he wants to do a picking to see if there was something. But it's not always easy.
Không dễ dàng để mà đánh giá cái đấy. Nếu như mà những cái hạch mà nó to hẳn thì có thể, hoặc là nó có nhiều hạch, nhưng mà trong trường hợp mà nó không đạt ở hai cái tiêu chuẩn đấy thì khó.
Thì có cần biopsy không? Just case if
nó quá nhỏ thì cũng chẳng biopsy được.
So maybe 1 centimeter in the Miller.
Over 1 centimeter?
Yeah.
Oh yeah, it's positive.
Okay,
Yeah,
positive. Nó trên 1
1 centimeter is big for
the soft diameter or the long?
The short.
Maybe
nó tính các cái
ngắn. You need the biopsy the lymph node or you low
ngắn.
No,
trên 10.
In the hilum, it's not possible for radiologists to perform biopsy.
Yep.
We cannot go there. So no, you do not perform biopsy. You just say, or it's more than 1 centimeter of short axis. We say, okay, most probably it is N+. We don't see, we say, okay, there is not. And in intermediate case, you discuss with the surgeon that is going to operate later, and we say, maybe some picking at time of surgery.
Okay. So
and
now,
one thing for the biopsy, it's a big tumor, it's right, but because you have only the posterior segments that are spared, you could have gone into the 8 or the 5 segment to go through the 4 and the biopsy. You could have gone through this here and biopsy here.
Why you don't?
We don't do it directly into the liver because also it's very fragile, and you can have a lot. If you do a biopsy in the good liver, in simple liver, you will see that you have a lot of blood. And when there are a tumor, it's a lot of blood and a lot of cells that can go into the cavity, abdominal cavity. So you always go to protect, to do not have hematoma or hemorrhage, and to protect the peritoneal cavity, you always go through a healthy liver. Even if it's small, even if it's 1 centimeter, you go through 1 centimeter healthy liver and then you biopsy. But you don't want to spill or to take a route to healthy liver, so to really healthy segment. So here you could have come from here. So here it's.
There is a tumor here?
I'm not sure. I think it's perfusion anomalies due to the thrombosis. You see, because here you see the lesion.
Yes. What's the...
Under ultrasound, you see better, but I think this is only perfusion anomalies. You can go from here or here.
The normal liver from here?
Yeah.
To the liver?
To the liver. To the tumor, yeah.
Cách chọn cái vị trí sinh thiết
it's just for another case, another
gan lành sang cái vùng u tối thiểu là 1.
Nhưng mà đứa này là đến lúc mổ chứ. The patient is after 7 course. The
Yeah,
patient
now
is
Yes.
we discuss
suspect
about
the
the
tumor.
Yeah.
Hoán có mổ được không?
Đâu, bây giờ
No,
nó bé
the
nhiều rồi chứ.
beginning.
Được bình.
Đây là lúc đầu mà. It is. But
Nó đang đơ này.
nó
chảy.
going up. But I think it's not significant. Because it was 4,000 before, after 6, and 600, 7,000 after 7.
Đóng cái đấy.
Just a matter of one dilution.
Do you think the biopsy is very necessary? You have to operate the child.
Yes, because we are using it for the algorithm.
It's a newest.
For the algorithm.
Newest.
Not in all cases.
Yeah, not in all cases.
But definitely was not biopsy. So now what is the status?
Yes.
Trumbo.
Yes.
The ring. Yes. It stopped here. And IBC now. Yeah.
IBC is clear.
Yes.
It's clear.
Clear.
Go ahead.
That is you have to do. Yes.
Now.
No lymph node.
No lymph node.
IBC clear.
Small tumor.
And
Yeah.
Okay.
Retake.
You did a good job.
Yeah.
Prospect.
Yeah, no, yes.
Prospect. Actually, the patient move the tumor.
Yeah, sure. The patient is not going to remove. The surgeon is going to remove. Yes.
Mổ gì đây? Cắt gì đây? Cắt gan trái.
Enlèverait le cas.
Còn cái
Phần thủy bên.
nó vào
Trumbo vào cả vào sát với lại cái vào sát ở đây, cắt ở đây.
Đời nó to nhưng lại ngon, còn đứa nó bé ré lên to.
Why? Why do you ask the question? Because it's probably important.
Because the thrombosis of the vein. Yeah.
Yeah.
It is a middle.
Yeah.
And in trumbo, yeah.
Sometimes this is why I asked Pascal and the surgeon, like, even if we don't see tumor, is it not better because of the extent of the thrombosis to remove the fourth segment also? Not
Segment.
the fourth.
Yeah, the
We
fourth also.
will remove the two and the third, but the
Mổ là cắt luôn cả 4 đấy chị ạ. Mặc dù là retake 1 nhưng mà mổ cắt luôn cả 4, tức là có phải retake 2. Prospect 2 because we cut them.
yeah, no, we say prospect 1 because we don't see lesion, but for the surgeon, they have to discuss if they take the fourth because of the vein, not because of the extent of the tumor.
Okay.
Vì sao hả?
Thế là vẫn sợ cái tổn thương cái huyết khối.
Cái huyết khối nó lan đến.
Có đánh giá. Mở rộng một tí bởi vì là cái gan phải vẫn còn nguyên.
Cái phân thủy vốn này vẫn không có u nhưng mà nó có huyết khối rồi.
Thì đã bỏ gan trái nữa.
We just
Chết được cái gì đấy?
We have case 9.
Yes.
How about the segment 4?
I don't know, I
Tiếp đi.
it's
How about the
debatable.
segment 4?
Em ơi tiếp đi.
The next
Des tables.
segment 4 or not. À la base, lui, il a dit, je crois 2 et 3 seulement. 2, c'est ce que vous traduisez. Ah, ok. So you leave the 4. So the fourth, no.
No. Just 1, 2.
No, it's good. It's hard to know. It's good.
Nó có tự dừng à? Sao cái lúc nãy
Yes, yes.
Okay.
Tiếp cây đi em. Next cây.
Are you decided now? You decided.
It moves. Let
They let it. Okay.
Yeah.
Okay. Can we go to the next one?
Yeah.
And then we have another one. For ending.
Sang tung mắt.
The last one.
No. Ninth and then the 10th.
Not last.
Okay.
The question is will length of our pregnancies. The patient wanted to chest pain and shortness of breath. For the first month, the child has nighttime coughing, mainly in the early associated with chest pain and shortness of breath during coughing and soreness. Medical histories on examination of diagnosis, the patient has no chest pain, no shortness of breath, both are well ventilated, soft abdomen, and blood vessel is normal. Density detects a right side anterior superior mediastinal mass measuring 30x and 22. The soft tissue density continuously used with the thymus, showing no invasion or compression of another structure. Abdominosity, so mesenteric lymph nodes measuring about 2 centimeters. IFP and SCG is normal. LDS and uric is normal. Bone marrow not important. Pulmonary rehabilitation tests are positive.
Yes, what does it mean?
What is pulmonary rehabilitation test?
Đi làm sao?
What is it? The score?
Ông hỏi đi. Ông hỏi cái gì? The patient had là cái gì nhỉ? Asthma. The patient have asthma. Then the colleague from immunology to check.
Oh.
Okay.
So what's going on?
This was diagnosis suspected for thymic hyperplasia and bronchial asthma. Treatment for child asthma and in the regular follow-up tumor. The patient is clinically responsive to asthma treatment.
Includes mediastinum, anterior,
mediastinal lesson thymus tissue and no change in size compared to others.
Not possible. The thymic tissue is not in the posterior part of the mediastinum. There is something wrong.
Ils ont mis anterior tout à l'heure. Là,
Yes, so the thymus is a wandering thymus. Okay, moving thymus.
Cái này theo dõi thôi đúng không? Sợ đến nỗi hung đấy đúng không?
Attention parce que la question c'est attaché.
But it's patient now, it's older patients, but you still have the
Yes, sometimes.
Yes,
It's crazy. But they, I don't know why these guys are keeping the thymus.
Yeah.
There are immunological reasons.
Có bị ảnh hưởng yếu cơ không?
No.
Non, il demande est-ce qu'ils doivent. La question c'est au follow-up.
Should we do something?
Chẳng làm cái gì cả, theo dõi something. How long you have to check exam?
I don't know. I am not a general pediatrician. I have to ask the radiologist what he thinks.
And how often you into exam?
Well, I want to see and to be sure that there is not a mass and it's only thymic hyperplasia. Yeah.
He wants to wait for her lawyer for answering.
Yeah, I'm waiting for the call.
Yeah. 9. It's a guy, he's 9 years old.
And some family maybe so worry.
Oh yes,
Check
the family is worried.
they check the child to exam frequently.
They read in the Google, maybe lymphoma.
Oh yes, for sure.
Yeah,
For sure. It
tao
might be.
gros, enfin, il est grand,
Might be.
ça fait 9 ans, mais
Like
non,
me.
il est pas, tu sais, il fait pas boule.
Yeah.
Yeah.
So this is the
Non, mais ça, c'est
radiology
parce qu'on fait en face.
is the king.
Can you see
of
the
the
coronal space? Ici, mais je
No, but it's nice.
see it on coronal also.
Because you see where it.
Do you want to see three?
We like to see what you want to show us.
Regarde-moi ça.
I'm not anxious.
Tu sais qu'on a suivi un patient comme ça, hein, qui a livré
For how many years?
ouais, un petit. On a suivi parce que c'était un peu bouliforme. Au
Yes.
final, on a décidé de le laisser tranquille.
Yeah.
Et nous,
You know, I have one question for you.
yeah.
What does it do to the thymus when you have asthma and when you are given corticosteroids? Yes, and after corticosteroids,
It can go up.
Go.
But
this is the story. It's just an hypothesis. It's an hypothesis.
ouais.
Nó có giai đoạn là con
Yes,
sinh.
you receive corticosteroid, then you stop corticosteroid, so you do something with your thymus. You play with the
The
thymus.
thymus is big, but there is no visible mass. If we really, really, really want to make sure that there is no mass, we can perform an MRI. We will see the best. If really we are worried, the parents have money and they're really worried, we can perform an MRI. On l'aurait fait.
Yeah, you should have done. Would have done.
We would have done maybe an MRI. The people are really, really stressed.
But never a PET scan.
No, an MRI. An MRI. If really everybody is stressed and voilà, stressed, anxious.
Rất là lo lắng để chụp em.
But like this,
Tuyến vung lại to trong cái trường hợp stress ấy.
Mais non, mais parce qu'on aurait vraiment
Tức là nếu mà gia đình có stress thì em rai.
Parce qu'on a des timons.
Et ça se glace, ça se verrait. Sur les règles, c'est énorme.
Ouais.
Là, tu peux pas se dire.
Ben là, on est moyennement sûr. So the best, if we really want to remove the thought of the thymoma, is to perform an MRI, because here the contrast of the sensitivity of the tissue in the scan in the CT is less than in MRI. But then if everything had the same signal and everything is homogeneous and you do not have really a hyper-intensity T1 or something, I will not do anything. Okay, I would let him be.
Cái này mình có thể chụp MRI để đánh giá nếu như mà nó mà đồng tín hiệu với cả cái tuyến thung bình thường thì mình không phải lo nghĩ gì.
And if you cannot
and it's like that, because you already had asthma, so just it's general pediatrician.
Yes, but you know,
Cái điều trị như nào?
not too much specialized, because if you are too much specialized, people when they see you, they are afraid, so they ask you to do more, and at the end of it, you have a sternotomy or a benign normal thing.
Yeah,
Yes, you can find.
yeah.
Yeah. If we think about is the thymus, it's a thymus the benign.
Yeah.
And when you recheck again,
If it's only thymus and there is no nodes, there is not a mass in the thymus, it's only thymus who is big, we do not check.
Yeah.
You do not need to check a normal thymus.
Yes, I understand. There was shortness of breath.
Because of the asthma.
Yes,
Not the thymus.
shortness of breath, but it's not because of the thymus.
It's a normal thymus. It's like you want
Okay,
to.
let's go to the last thing.
yeah. Tiếp đi em.
Tuyến thung phi đại.
Last case.
Yes.
Not last case.
Not.
A lot of case.
No.
You should have done what time.
Okay.
The patient presents with pneumonia. During treatment with pneumonia, the patient incidentally detected result peritoneal mass. Medical history is on the timeline.
On examination, patient
Đấy cũng hỏi nhiều kinh nghiệm hơn.
she knows which loss, and knowing no middle but diagnosis on
Pneumonia.
Tổng gì là cái căn bệnh kiểu
renal tumor about spinal
Tăng nhiệt độ lên kìa mọi người.
Đăng lên à?
Và tăng lại.
The
first part.
Let's get sequential and next like
Let's get sequential.
is about two reasons. Urine cholesterol hyper and bone marrow affected left on marrow metastatic.
Oh. Ring in hand.
Some lesson in both sides. Focal eroid and enhancement.
What? Wow.
Let's get to the
No, it wasn't me.
And here, spending.
These two pneumonia.
Yeah, stage 4 carcinoma with LTS positive hyper blood pressure. Treatment blend with the and
Bone.
Evaluation after rapid course on August 2025. Immunogenicity and chest show some lymph nodes. The red show very small mass, measuring about 5 centimeters. Some lymph node along the abdominal and lateral arteries. And right function have some lesson.
CT lúc normal.
L1 to L5, F1 marrow lesson, and bilateral one marrow is normal. After rapid course and 3 cycles on November 2025, the tumor slightly equally compared with August 2025, but the tumor in arenal retroperitoneal mass is about 11 centimeter. This injury compared with August
1. Just
So you had a PET
I think I saw it. No.
Yes.
Say never. MRI.
No, this is a
PET
PET.
no, MRI. It's an MRI. C'est la séquence de gestion.
Ah,
MRI.
sorry, I'm sorry.
C'est trop peu, hein.
What you do?
We do it.
Things like that.
We do.
We are anxious when we see that.
Ah, sorry. Yes, but we were not following it.
No.
And just if you go up, I saw you
But
made
on
the
the other
next
hand,
one
those
for
you
G1.
do very
And you
well,
had the sequence, I saw it. Can you do that in checking?
T'as l'impression que dans la tumeur, on n'a jamais rien.
Mais ça s'appelle IRM entier. Hein.
Ouais.
Duran membrane. Here. Here, yes. Yeah, here also. Okay, yeah. Il y en a dans la tête.
Yes. Non, dans la tête, dans la boîte.
Dans la boîte crânienne. Je cherche dans les vertèbres. Ok, en lombaire, elles sont pas normales.
What is the status now?
Ouais, ok.
We have some surprising response in the abdomen. Because when you look at a tumor like this with full of calcification, usually it doesn't change much on the treatment. So you may You gave Kojak and then 3IT. And what is the status now?
Yeah.
About the primary? I know that the bone marrow was negative after Kojak. You checked already the bone marrow after Kojak. And what is the status now in the abdomen?
We have a recent neuroCT. We have a recent.
Yeah.
Oh, MRI.
MRI. Why not?
You have action. Actually, it would be better, but no. Okay.
Yeah.
Il y a toujours des lésions dans la moelle. Hein.
Yeah, yeah. Ça peut pas disparaître. Yeah. Non?
Okay. Do you have si ça peut disparaître, comme les lésions. Yeah.
What about the abdomen?
Do we abdominal? Yeah, accidentally two or something on the abdomen. Yeah. So the nodes shrink, the tumor shrink, but we still have all the same image defined exactly. We have the same here.
Yeah.
Because it's shrinking very vascular.
Shrinking.
Encore, tu veux comment? Si, mais c'est une IRM, pas très beau, si tu veux. Ouais. Ils sont bougés les intestins et tout encore. En fait, bon. Okay. What do you do? Sarah? You want to play? Je veux bien revoir. Tu veux voir quoi le retour? On a qu'une IRM, on n'a pas de scanner. Les dents, les IRM, can you put the coronal plane on B2 or something for Pascal? You have it in the first, oh yeah. Or the last one. No, not the head, the abdominal. The total body. Yes. Voilà.
Yes.
Can you zoom into the abdomen? Voilà.
3 ans. 2 ans.
Yeah. 2 ans? Ouais, ça.
Au diagnostic. Hein.
Sans compter les ganglions un peu au-dessus, un peu au-dessus.
So, this is very difficult to decide what do you want to know. You want to know if we agree for high dose therapy or something like that. What is the question? You want to share the case, but what for? Is it to tell that the surgery is not possible? Yes, it's not. Is it to tell if there is sufficient response to go for high dose? We know that the bone marrow is negative, and about the bone, what can we tell only comparing MRI? Not much. Not much. We can just say the signs of the disease are still there.
Yeah.
The sign of the disease is there, and we don't know if it's an active disease.
Yeah.
I think the only way to do in this situation, I'm always telling the same thing. I'm very sorry, is to see if there is if there are positive spots with FDG, because you do not have MIBG. So probably if you have a negative PET FDG, at least in the distal parts, in the bone disease, then probably you may discuss to go for high dose. But if you see remaining disease in PET FDG, I think you have either to continue with with IT if you think that IT was doing something, but I have no ability to tell because I haven't seen an evaluation of response after Kojak, or I've seen on the slide on the left that it's not the same way. The rapid Kojak, you were doing a CT on MRI, because I have the impression that the disease is growing again. Is it because I haven't seen I don't know what was done in August. In August, was it on CT or was it on MRI that you had this definition? Because when you look at only the results, you have the impression that this is a progressing disease, but it is unchanged. So
No, it's for chest CT.
yes, for chest, but I have no conclusion for after rapid check.
August?
And IT,
Yeah.
is it
August 1.
suspicious of progression?
MSCT?
Or is this just a way to look at it? You know, if you compare a CT scan to an MRI, you will measure on CT scan only the abdominal thing, and an MRI you will probably measure the whole height of the which is encompassing the abdomen and the chest. So you will have 11 centimeters, but it's not really a progression. So I think it's not a good way to compare.
Mais là, c'est le scan de haut et à droite, c'est le scan de maintenant. Yeah.
Do you think it's worse now?
No.
Or do you think it's better now?
No, it's better. Better, yeah.
So
bây giờ tốt hơn à?
It's
Nó
better.
nhỏ hơn. Thế giờ ai đo là năm?
It's better.
Mày đo á?
Kết quả report.
So
It's better.
Obviously what was written on the slide is not the reality. It's not reflecting the reality of the patient. The reality of the patient is that you have continuing response.
Yes.
Whether it's due to Kojak with a continuing effect, or whether it's due to IT, I don't know, because we cannot dislocate the two. So I think that's the most important thing, is to know what is the activity you have. You have a lot of cells which are eating sugar. So in the PG PET, you see cells which are eating sugar. So if you have not too much things, I think you could go for high dose. And to perform not surgery after high dose, but to perform radiotherapy
It's true if you see that.
with very large fields after high dose. So what do you think?
Hồi tháng 8.
Specialist here of glioblastoma.
Em check lại xem là bây giờ cái phim bây giờ tháng 11 với tháng 8 thì có phải là nó phát triển lên không, hay là đấy là
Nó bé đi.
Nó bé đi.
sao tháng này report thế kia.
Attention à la date.
I don't know.
Maybe the have mistake with the report because Dr. Hạnh said vào maybe the reduce the size, not the grow.
Yes, yeah, I understand. So I think that what you want to do now?
Alors, tu peux enlever une partie.
Bây giờ mình muốn gì? Có nghĩa là mình thấy là cái tác dụng, cái điều trị nó có hiệu quả.
Yes.
If you take a part of it, if you have
like this.
Like this.
Yes.
If you have a real volume. On peut revoir le scanner.
Which one?
Can you Pascal, the last one.
Non, elle est en train de
Last one, right here? Yeah.
This is the last one.
Pascal want to see it in big and to be sure if we can remove a point or not. The newest one is this one. Okay.
Because you are always disappointed when you make surgery for such case. You take risks.
Yes.
To take the very few parts of the tumor. So you are very disappointed after that. And with the radiotherapy, you do the same. I think.
Yeah.
Corona, yeah. The last one. Yeah, the last one.
For surgery.
Okay.
Don't go for surgery. Alors, moi, je voulais juste savoir this part, because we don't, but if you have a benefit of that. Alors, il faut voir, voilà.
I don't think we are going to have benefits because we have a risk of having complications to stop.
And we want to do the
yes, and we like to have the high dose therapy first. So as long as you are happy with the bone marrow, please go ahead.
Yes, we check the bone marrow.
It was checked.
Yeah.
But you recheck before collecting.
Yeah.
And are you going to collect in a hematological stable status, or are you going to give some chemotherapy?
I think we have some patient like this after 3 IT.
Yes.
The patient is have a lot of residual lesion to
Bone.
Yeah.
Yes, but the lesion in bone you cannot evaluate using. I think the way to evaluate the lesion in bone in your hands now is to make PET FDG.
Very cautious with bone.
If you have negative PET FDG in the bone, go ahead for chemotherapy or collection of stem cells, and then I do. Okay.
Diffusion tức là nếu mà còn tổn thương.
Can you do that?
We usually have a lesson in the bone checked by the MRI diffusion.
Yes, but
we need to biopsy the lesson. It's easier the lesson can take, and then some cases it have tumor. What do you want to evaluate?
yes, but I would not bother doing that because it's complicated. Whereas if you do a PET CT, you will have the response. You will have a whole response, a response of everywhere in the body. You know, you don't. If you take a specimen, you take a specimen in one side, in one site only. If you do the PET CT, you will see everywhere.
Yeah, I know. But before we have the patient have a lesson in the MRI diffusion.
Yes.
But in PET CT is the negative.
Yes.
But we check bone marrow,
and it was
bone
positive.
biopsy, and then the pathology
Yes.
sees in the tumor cell.
Yes, but it doesn't mean that these are stem cells. You know, you see stem cells, you see cells, but you don't know if those cells are able to metastasize or this thing like that. So I think the most important thing is to have the activity of the cells. Are they multiplying, so things like that? And you don't have that when you look at the cell. They can be differentiating and nothing else. So I think it's very important to have the activity. And I understand you have, but what did you do to your patients? Did you stop treatment and did you give palliative therapy? Okay.
If you have active lesion on your PET scan, you would do like what, 3 IT?
I will either continue with IT and recheck later, or I will change to topocyclo.
Yes, but it's always the same problem. You don't know whether you had active lesions and diagnosis. Because now, even if you have cells in your it's a response to chemotherapy.
Đồng vô nói như này làm sao mà nó thuốc được. Mổ thì không mổ được, thuốc thì không đấm được.
We can do it. As long as the disease is not growing.
Yes, as long as it's not growing, is decreasing and have less
patients. Yes, so the medicine can go here.
Yes. No. Yeah. And even if you have cells in the bone marrow, you can collect the cells.
So I would do high dose therapy. I would discuss the double high dose or things like that. But you know, for one patient, you can just tell, please go ahead and do something if you can have some hope with the patient. Okay. Can we?
Excuse me. I asked about the plan is for this patient. The patient have a residual tumor. Is a radiotherapy for this patient have some some lesson in the bond because we don't have MIBG, only the MRI diffusion.
Yes, yes, I understand. But
yeah.
what we don't know. We don't know because the American people, when there are like 1 or 2 spots left after high dose, they do not only radiotherapy of the primary site, but they do add on radiotherapy on focal sites which were still positive with MIBG. So they recommend to do, but in your case, your patient has a very, very important disease. So you will have probably, if you are only judging on diffusion MRI, I don't know if you are doing well. I don't know what it means, because you can have diffusion, but cells which are not active in a sense that not acting to make metastases. So I think for this patient, if you don't want to stop the treatment and give palliative therapy now, I think you can go ahead for high dose therapy. Okay, I'm sorry, I will have to go in 15 minutes.
Yeah. Okay.
And we all are going to go. So I think that we can see one last case. If you have one last short case, not more than 10 minutes.
Giản thôi. One last case. Yeah, có kênh nào đơn giản không thì ấy thôi. Nhanh. Nhanh.
Yes, bình thường cứ bóc một số đông đâu của người ta.
Bây giờ người ta cho đúng giờ thôi.
Bóc một số đông của một bác sĩ phẫu thuật, anh em mình quen rồi đấy.
Tóm lại là ca neuro nguy cơ cao, bác ấy bảo là nếu còn tổn thương trên MRI diffusion thì go ahead đi đến hóa trị liều cao, bởi vì là cái biopsy đấy nó cũng không phản ánh hết được cả, nên là vẫn cứ đi đến đấy chứ đừng có palliative care.
Okay. Do you have a last case or not?
Yeah.
We don't need. If you have.
Go sau đi.
I think people are getting tired.
You have an appointment.
So the very last one.
Anh em. Medical.
Hodgkin lymphoma.
This case is difficult to. Này là.
From the military hospital.
Yeah.
You see, people are very happy with it. Okay, go ahead.
That case is about Hodgkin lymphoma. Our patient is male and who were 8 years old at diagnosis, and he was admission in July 2024 with fever and weight loss. His medical history is normal, and at diagnosis on the abdominal CT, we found lymph node in multiple locations size about 7 centimeters, and and have a hepatomegaly and splenomegaly with splenic infiltration. On the chest CT, we found lymph node, right human and littoral clavicular overlap with size about 26 and 18 millimeters. When brain MRI was normal, bone marrow aspiration was normal, and on the PET-CT scan, we found lymph node along the stenotragus also on both sides, and mediastinal lymph node and abdominal lymph node with FDG positive in shoulder blade, vertebral blade, and pelvis and femur. And he was performed biopsy on the abdominal lymph node and the red.
You want to see thinner?
So we were diagnosed with coma stage 4B, and he was with aromat BSL T1 with
the first image.
During treating with OFBR course, he had anaphylactic shock with ectozyte, so he was treated with the course OFBR with the side. And then,
do you want
of course,
to see
ABD combined with the pregnant map. Evaluation after treatment. after 2 course of OEPR without etoposide, on the PET CT scan, we found here partly response with the was 5 course. There was still lymph node in chest B and abdominal CT. After 4 course of conduct, found he had to respond with lymph node in abdominal CT size about 27 and 90 millimeter, and the mediastinal lymph node size about 7 millimeter. So he will perform directed incomplete peridural and left retroperitoneal lymph node. And the history after surgery.
Do you want to
present a
last one
cell with
now?
CD30 positive, and then he was consult with expert, and he will continue treating with 2 course of ABD combined branduzumab, and
disappear.
He had
Partially
response. There is still had lymph node in abdominal size about 1 centimeter, and the chest D was normal. And after 4 course of ABD combined branduzumab, he will perform PET CT, and the rest is they still abdominal aortic lymph nodes measuring about 5 and 6 millimeter, and several left retroperitoneal lymph node and cervical lymph node measuring about 11 and 8 millimeter, showing increased FDG uptake with a SUV max about 4.8 with a DLV score is 4. Now, in clinical examination, we didn't find any lymph node. And to summarize, we had a male 7-year-old patient, and he was diagnosed with Hodgkin lymphoma stage 4B, and he was treated with Euronet PSL T1 with TP3 regimen, and include 2 course of OEPR with etoposide, and 4 course of conduct, and 3 radical abdominal lymph node, and 4 course of ABD combined branduzumab. And now, after treatment on the PET CT, we found their view score is still 4. So
Sufficient.
our question is, what is next treatment plan for this patient? Should we biopsy the radial?
Please don't take the lymph nodes. This is not the treatment of lymphoma or Hodgkin lymphoma to take lymph nodes. So I think we discussed already this case, but with another patient on Monday. Remember, we do know, or we were informed by, and it was confirmed by I don't remember if it's Naila or if it's Sarah, that when you look at PET scan, PET FDG scan in patients receiving brentuximab and chemotherapy, we cannot take into account the Deauville score, because we are, and especially when you see that the nodes are so small, we are not. So the question now is that we don't know what to do, because this patient received already 6 courses of regular chemotherapy without etoposide. I agree, the parents were right to refuse etoposide desensitization.
Allergy.
Yes, they were right. The parents were right to refuse, because I think it's not going to help. And he received 4 courses of AVD, so a lot of doxorubicin and a brentuximab added to that. So now you cannot tell. You can just tell either you add toxicity, asking the radiotherapist to do additional radiotherapy. Let's say what, where. Where do you do radiotherapy? On the residual lymph nodes, 20 gray or more, or just stop there and follow up. So I think there are 2 possibilities, but I would never go to take the lymph nodes. This has never been the way to evaluate this disease.
surgery and histology to evaluate response in Hodgkin lymphoma is not a gold standard. So I think this is I think that we have to or let's say you have to see with military hospital where they take their advice. Do they get it from Germany, from Russia, or from someone else? We don't know. I think it's a very strange way to work, and it's not the first time because we have seen 3 cases with military hospital. And are you obliged to be involved in those cases? Are you obliged, Dr. Noklan? The parents are asking you, or the doctors are asking you? The parents. So, but when you come after the other, without
The child has a clinical
Yeah.
abdomen areas and things. The parents and
Why do they go?
military hospital shut down. And the parents one medical team. We
because at the beginning the patient have a severe symptom, and then after allergy, I check if allergy if the size the patient maybe the family so worry the patient have a relapse, and then Cường ơi, Cường đưa bác cái xuống cổng 2 để bác ấy đón gì? You get picture.
I will go to the hotel because the car was there. Okay. But I think definitely we cannot give advice. The only person who give advice maybe she can probably
I'm not
discuss.
sure should be the radiation.
Yeah.
Shouldn't, but we give treatment. Shouldn't.
I make it look
What
Stop.
Cái này tiếp tục điều trị.
Không dừng và không xạ trị, không gì cả, theo dõi. Tại vì là bác có tính quá nhiều mấy
Tại bảo ở trong này vẫn còn một ít.
Máu là gì?
Ok. Thank you so much.
Đợt này đang không có máu ô, cái con u ngày mai là máu ô đúng không?
Chị có biết đâu.
Đi. Cái thằng Khang ấy sao lại check? Không check luôn để có trả lời cho bạn là không.
Nhóm máu của Nguyễn Minh Khang. Nhóm máu gì? Nhóm máu gì?
So the patient tomorrow, neuroblastoma. We do the CT scan in the morning.
Yes.
And we operate
At maybe 10:30 or 11.
We have to check again the blood.
Không chưa?
Because today we have some patients have to postpone.
Chắc hết rồi.
Not enough blood.
Cảm ơn em nhé. Đều là lần đầu hết à?
Chị nhờ tóm lại em nhóm máu gì em?
Đây đang check chị.
Chờ tí em.
Có xem không?
So if we don't do the neuroblastoma, can do the pancreas.
Được rồi, xem.
We don't need blood for the morning. To choose, but you can change.
Hết rồi đúng không?
Maybe tomorrow you can go to there, or we need somebody to pick you the hotel. You can because the doctor will show.
Chị là máu gì?
Yeah. Okay.
Nhưng mà thần kinh là máu gì? Cả hai đứa cùng làm ô.
Em mở ra đi.
9 o'clock. In this room.
Cái này nó còn mở đấy.
Yeah, maybe you have WhatsApp and call me. Yeah.
Okay.
Hình như là nhóm máu ô hết đấy em ạ.
When you stop in the any.
When you're at the entrance, we go.
Okay. Nhóm gì? Ô gì? Cần bao nhiêu máu nào? Mày cần bao nhiêu máu?
Không.
Máu với chị không có khó khăn gì cả. Mày cần bao nhiêu?
Ăn hết, ăn mấy.
Tao hỏi mày cần bao nhiêu máu tao sẽ lấy cho mày. Do you want to
Tóm lại lần này để lấy con oxy, bởi vì oxy không cần máu.
nếu cần thì chị order từ viện truyền máu cho em, có gì đâu.
Thì bây giờ bệnh nhân ghép gan cũng đang còn cho order, đang còn chờ.
Làm được, mình không phải lo. Ghép gan nó là máu có xạ thì nó khác, còn đây là máu thường. Em cứ cần bao nhiêu em nói đi, chị sẽ hỏi lại cho.
Quan phương vụ đấy chị thế thì chị hỏi cái mail.
Chị ơi, chị xem là họ cần đi xuống
Bây giờ đi xuống đi về mà.
họ. Okay.
Do you want to order how much?
Cái bạn cái mail cho đi.
How much?
Bây giờ em có tìm gì? Làm xem lại từ bây giờ gì ạ? To không? Lúc trước nó
không nghĩ được em vẫn không chảy máu mà.
Nhưng mà để tôi bây giờ
cũng hỏi thằng đi xem cân.
Chỉ là xem tuổi có
Thứ nhất là như này này.
Về để chị xem cái
Tại vì gọi bệnh nhân lên rồi bảo hứa nó là chờ 2 tháng giờ mới để chuyên gia mổ, thì giờ lấy nó lên đến nơi bảo không mổ. Mày cứ bọn tao mới là người đứng trả mũi chịu sào giải thích bệnh nhân.
Ở đây hả?
Thì đúng rồi, nhưng mà đấy cho khoảng 500 đi. 500 là đủ cái ô to thế.
Tại vì là em hiểu vấn đề bệnh nhân người ta chờ 2 tháng rồi để chuyên gia sang mổ, xong bây giờ gọi người ta từ nhà lên để mổ, xong rồi bây giờ bảo là không mổ nữa. Mình nếu mà là bố mẹ mày là bố mẹ đứa bệnh nhân, mày có khó chịu không?
Không máu thì
bình thường.
Thì bây giờ chị sẽ gọi cho em xem có máu hay không.
Em thì em
chỉ có mỗi cái khối đấy thôi đúng không?
Bởi vì em sẽ phải ra giữa ca mổ.
Khối đấy thì ok.
Không có gì.
Bây giờ muốn xem lại.
Bây giờ hôm nay
Chị em anh nhận đi.
Hôm nay chụp chắc không.
nó có hơi đau hàm để trên cái hàm này nó bắt đầu hơi.
Mấy giờ mổ thì con em ra sớm mấy giờ mổ đi.
Thế thì chị hỏi tháng đi chị chốt là với anh.
Nó thì chụp có mỗi một ít cái
nói
hàm dưới này.
Mổ thì máu gì? Nó mấy tuổi nhỉ?
Nhưng mới có hơn 1 tuổi thôi.
Có hơn 1 tuổi gì mà lít máu, mày đùa ra được?
Đấy, chị chả đọc ngực bên này.
Đã bảo là cái name mới biết cơ mà.
Cái đứa đó có tên trong lịch mổ chưa?
Thôi chị ơi.
Rồi.
Đứa nào dẫn các bác ấy về đi xuống đi bộ các bầu rồi. Bye bye. See you tomorrow. Đây. Phòng này 9 giờ.
Tất cả các ngày sau đều ở đây nhé.
Chào nhá. Con này dẫn khách xuống cái gì cả.
Bạn trả lời
hỏi họ là họ đi cổng nào. Cái này là có biết đấy. Bộ xe của bộ đấy. Xe của bộ.
Xe của bộ.
Nói bộ thì sao nữa?
Chị An à. Đi bộ.
thế là về chứng nhận.
Đâu, bảo Sơn chị.
Để chị gọi bên huyện nó truyền máu nhá. Để
bây giờ muốn xem là nó có vấn đề gì không thì
anh mổ 2 lần được. 2 khối máu bên thằng còn này thì anh mổ 2 lần được.
Thế thì xin lỗi thì ở mai mổ nó con
sợ xương nó có đau bụng hay gì không?
Không chỗ nào
không thi hành chứ cái gì cả. Nó không dày không giãn, thận thì ngấm thuốc đều. Gan không to, lách không to như mua đồng nhất.
Không mới hột vàng thôi.
Không có hạch
để gì?
không thất. Xem phổi có gì.
Không biết lấy hiến máu bao nhiêu như thế mà không được cái đơn máu nào à?
Không sốt hả?
Nhân sau nó phải xử lý chứ làm gì có ngay được.
Hiến máu qua em đấy.
Không thủy lên nhóm để báo
đâu. Hỏi một tí với tình hình máu ô hiếm hoi lắm à?
Xin phép em còn nữa rồi. Em
thì với phải hợp anh
để xoa lượng phân phối thì viện hầu như cho rất ít. Và bên em phần này là đủ. Sau khi là thẳng thắn là bên em rất đủ.
Tại vì là bọn chị đang có một cái bệnh nhân ngày mai muốn mổ cái u sau phúc mạc mà chuyên gia mổ, mà bây giờ bảo không có máu ôn hoãn. Thế nên chị mới muốn hỏi là xem liệu
phổi không có gì
không thì
không hành không gì hết. Negative hết.
200 chưa chắc phải mổ, mà mổ này có máu.
Phổi trong vắt thế này để đi chụp em ra các lớp vi tính.
Đặc biệt này và em hộ.
Thế thì chị gọi luôn nhá, để mai nếu mà bây giờ cấp máu thì được bao giờ
khám nhỉ?
để còn học với chuyên gia cấp luôn được cái gì?
Bác sĩ đi em hai đi.
Không có gì đâu, sao các ông bà mổ được thì mình mổ thôi, tại vì chuyên gia sang để mổ rồi bây giờ bạn có máu hoãn mổ ngay từ
đặc biệt
cảm ơn nhá.
Chị nói nhiều khi mà nghe không hết đâu.
Bảo nghe nó bảo mày là có máu mà riêng tao lúc nào cũng có máu, mày nghĩ chưa?
Đấy là chị toàn đi kênh kiểu gì chứ bình thường
kênh kiểu gì đấy là kênh của việc bọn tao.
Còn em là lúc nào cũng kênh khác anh ạ.
Thế sao hôm nay ông xin đi?
Có biết được đâu, mày có nói đâu.
Hết máu đâu.
Tao có biết được là mày bị phán vì không có máu đâu, mày có bảo gì đâu.
Chị Lan thì chắc chắn là xin được.
Kinh.
Trời ơi, gần này tuổi rồi chị. Nó phải
Xin, cứ đi xin máu.
Tại vì là
Còn cái con u tụy nhá là thứ 6 chưa chắc đã làm đâu nhá, bởi vì là tại vì em phải xin đến cái anh Hiền cả anh Hiền tâm đều đi hết.
Hello, chị nhờ một tí là có mai có chuyên gia mổ một cái ca bệnh nhân tên là Khang ấy, thì bây giờ phòng mổ bảo là phải dự trữ máu khoảng 500 ml máu, thì máu ô đang thiếu đúng không?
không
Liệu
liệu
mày
em
có
trùng thất. Phải u đâu.
Cái tuyến hôm đấy á,
tuyến
tuyến ức tùy đại.
vừa mới gọi xong cho chị Lệ.
Và chắc là có cái tên riêng đấy, mình không
nói được thì chị có thể phát cho mình 500.
Ông ấy bảo là giống như là cái mũ ấy,
em
đi vòng mà.
sẽ gửi máu xuống dự trù xong em lấy cho bọn chị để mai 10 giờ.
Có thể chụp cộng mình cùng một gia đình lo lắng nhiều.
Stress. Nhưng mà cái tuyến vung đấy nó cũng bị ảnh hưởng bởi stress đấy nhá.
Không, chị vừa mới gọi xong, nhưng mà tại vì bây giờ rõ không mới ở khác mà em thấy
không, có nghĩa là nếu như mà mình thấy nó đồng nhất trên cổng từ thì nó đánh giá cái mô của nó tốt hơn rất nhiều so với các linh tính. Ví dụ như toàn bộ cái tổ chức đấy nó đều là
hiến máu đồng tiến trong con mổ và có hiến máu thằng mổ đó không.
hơn nữa nó cũng còn có cái đi cực nữa.
Một người trong một người hiến đây này chị.
Nó mổ xong thì 1-2 hôm nó hiến, nhưng mai nó ngồi nó trông con nó mổ mà nó đi hiến thì nó tâm trạng đâu cho nó hiến. Thì cần hiến thì nó hiến sau, chứ bây giờ bảo mai người ta mổ, bây giờ người ta đi ngồi người ta hiến
đây
máu.
Cái xương của em
Mình mà là người bố sao mình có đủ được ra tâm trạng đâu để đi hiến máu được cả em. Thế gì à? Hơi khó nhau thế.
Chị lại trả lời có, chị nói chị lại là chị xuống
chị đây.
chúng em đăng ký và tối cho chị lại chuyển cho chúng em ạ.
Này cái răng của nó chỉ có mỗi cái hàm dưới này này, nó đau ở đâu em?
Đăng ký máu tối đi lấy nhá. Mày cứ làm như thế mình chứ mà nó gửi được.
Đau ở đâu?
Nó còn lằng nhằng lắm mà.
Cái con Huyền này nó thế em ạ.
Chữ tập loa đã
Tắt lâu rồi. Tắt lâu rồi.
chưa tắt mic không, nó điện vào vẫn còn mic.
Khổ lắm, tắt rồi đấy.
Người ta bảo là có tiếng.
Chưa tắt rồi mà, tắt rồi thì còn tiếng ở đâu ra. Không, vừa gọi điện cho em bảo vẫn còn tiếng nhưng mà vẫn chưa tắt.
Chưa biết được cái máy chủ kia chưa?
Nó đau ở đâu? Đây.
Nó đang đau ở xương hàm chị ạ.
Này xương hàm này. Xương hàm bên trái.
Con Huyền này mẹ hôm nào cũng là tôi phải cho nó đi.
Xương hàm bên phải.
Chị em tôi lên trước này.
Nó chỉ cắt đến đây thôi. Cái phía trên này không cắt.
Bệnh nhân xuống